to get through all of the exciting conversations we have planned for this morning. All right. Well, hello, everyone. I'm Dr. Catherine Galloway with Dava Oncology. It's my pleasure to welcome all of you to this morning's regional colloquia on multiple myeloma. Thank you so much for joining us here in Washington, D.C. To dive deep into the world of CAR-T and multiple myeloma. We are really interested in going through some of the updates from ASH, the most recent conferences, digging into what you guys are thinking about and doing in your practices today, and understanding a little bit about where you see the future of this space going. This is a rapidly evolving space, lots of new things coming, hopefully in the next year. So this is a great opportunity to be in a room together with friends and colleagues and really explore the space together. So we appreciate all of you being here, and we're really looking forward to everything you're going to contribute to this morning's program. We have a fantastic speaker panel. Unfortunately, Dr. Davila is not able to join us. He will be missed, but thankfully we still have three excellent speakers here for the program. Dr. Ajay Nuka is here from Emory, Dr. Binod DeCall from the Medical College of Wisconsin, and Dr. Sandra Mazzoni from the Cleveland Clinic. So thank you to our speakers. We appreciate your commitment to medical education. We're looking forward to your talks and all of your insights during the panel discussion. So here's an overview of the program. So the way this is structured is we'll have 4 lectures, each followed by some time for discussion. Most of the lectures are really heavy on the data from ASH. You guys are all pretty familiar with it, I'm sure. And so this is really truly an opportunity to level set and then dive deep into the conversation and really get to hear what your thoughts and opinions are on some of the edges of the field and where this is going. So the first half of the program will talk about efficacy data predominantly and patient selection for CAR-T. Dr. Nuka is going to kick us off with the latest data for second-line CAR-T and multiple myeloma, including the data for standard risk patients that was just presented last couple months ago. Then we'll have Dr. DeCall talk to us about some of the evolving ways we think about risk frailty, as well as some emerging strategies in early line multiple myeloma. So bringing CAR even earlier in the space, bringing bispecifics early, how is that going to change our sequencing strategies and how we approach patient selection? We'll take a break so everyone can recaffeinate. And then in the second half, we'll talk about toxicity, which is a big piece of the story here. Dr. Mazzoni is going to talk to us about predicting and mitigating the risk of our delayed neurotoxicities after CAR-T. So there's some new strategies and ways of thinking about this. And then Dr. DeCall is going to talk to us about managing the delayed toxicities after CAR-T therapy. We will have plenty of time to answer questions, dig into your conversations, and we will conclude the meeting promptly at noon so that everyone can get on with their Valentine's Day. Happy Valentine's Day, everyone. Before we dive into all this content, we're going to go around the room and do some introductions. I think everyone knows each other very well here in this room. But we're going to talk a little bit more specifically about how many multiple myeloma patients you've been treating with CAR-T. So let's say BCMA CAR-T in the last month. We'd like to hear what trials you have open or plan to open soon, maybe what trials you're most excited about. For the third bullet, in your practice, what's the single most significant barrier preventing more patients from receiving CAR-T? And then if you could, just for fun and so we can get to know each other a little bit, if you could eat only one food for the rest of your life, what would you select? So I'm going to start on this side of the room with Dr. Ajay Nuka.
Thanks, Catherine. Thanks for having us. So I'm from Emory, and this group, that everybody knows everyone, I believe. So the number of patients that we see as an institution, we treated 120 BCMA CAR-Ts last year. On an average, we do around 12 to 15 this year. That's a projected number for the rest of the year. So we're 10 of us, and my share, based on how long I have been there, probably is around 20 to 30% of all that number. So what CAR-T trials do you have open or plan to open in my center? So we participated in the CAR-T2 trials, all of them, but it took a little longer for us, so our enrollment has not been as robust. So as an institution, what we have tried to do is to shorten our activation timelines so that we're going to open the trials very earlier on. So that led us to open newer trials in the last 2 years where we're opening very quickly. So we do have the Imagine-3 trial open. So we do have the anito-cel experience. We do have the new Durga trials that are coming in, so which are targeting BCMA and CD19. So very excited to see the data, and we saw a glimpse of that at ASH. And more exciting trials with Colonia. We're planning on opening them sometime in the first quarter of this year, as that was one of those late-breaking abstracts and that drew everybody's attention. So those are just a glimpse of what we have in terms of the CAR-T trials that we've open at our center. What's the single most significant barrier preventing patients receiving CAR-T at my institution? So we have an advantage and a disadvantage. So we are the only academic center in Georgia. So the referrals always come to us. So the complacency exists in the same way because we are the only academic center again. So we literally what we want is that pipeline to be created where every patient should be considered for a CAR-T or a bispecific, discuss with us before we make a plan. And this collaboration has happened very well with the community. But still, I feel that is a significant barrier in terms of more referrals that are not coming our way. And there's always a room for improvement. And that's probably where, if I have to focus on one aspect, that's the process improvement of how to communicate with the community and helping them understand what exactly the CAR-Ts are bringing to the table. So if I could eat only one food for the rest of my life, I'm boring. But if that's the only thing I have to eat, like I would eat the Thai green curry.
Oh, very nice. I don't think it's boring. Sounds like the boring answer is when someone's like rice. It's got all the different proteins I need. I'm good. That's a boring answer. So green curry is still a great answer. Sorry if anyone was thinking rice.
I'm
Well, please still do our, we appreciate it. Okay, Dr. Sandra Mazzoni, and thank you for pulling your mic closer. If everyone can pay attention to keeping their mics close, we appreciate it.
We have very similar numbers to what's happening at Emory. So I don't really vary on that answer. As far as CAR-T trials, I'm trying not to oversell because I think I'm one of the only ones that has someone else on my institution here. There's just a few people down here, but we have a lot of CAR-T trials that are open, and we're also very cognizant to make sure we can actually enroll onto all these. So we try to make sure that they're not competing with one another. We're a large amyloid center, so we have pretty much any study that comes out in amyloid, we will open it. We have 2 allo CAR-T studies. We have the GMT20x1080 through BMS. We have the CARTITUDE studies. The one I'm most excited about, probably the CAR-T study for CARTITUDE-10, where we're going to do non-transplant intended upfront. I think that's going to be interesting to see all of that data. The most significant barrier is definitely caregiver support. One food I could eat for the rest of my life. I want to say pasta. My trainer would tell me to tell you something like enchilada caprese or something that's much better for me.
Pasta's more fun. Thank you
Yeah.
so much, Dr. Mazzoni. Dr. Ataya Sivanasanka.
Hi, so I'm from Indiana University. So I'm kind of similar-ish to what Dr. Nugas shared. So we're also a state institution. So if you draw a line about 2 to 3 hours away, that's really our radius. So how many patients? I'll say that we're expanding. So I think the number is probably about 8 to 10 a month. There are certainly more patients who are eligible, and we are certainly still the bottleneck right there. What trials do we have? So, I mean, I think we share commonalities across. So the still largely BCMA targeted CARs, but also we'll be opening the dual targeting as well. The significant barrier, I honestly think that if my patients were being referred specifically for CAR-T, there's actually quite a bit of a pushback from the patients to say, why do I have to do that? I think we're a victim of our success in myeloma because a lot of things can work really well. So, and yet when people need help, resources and whatnot, unless they're already slotted in for a particular product, the resources are specific to the product. Like if you're referred to get a CAR-T until you actually are having a case submitted, there's that gap between how do we get you from having diagnosis of myeloma to a center that may offer CAR-T, right? So I think relationship with the community is key. I strongly believe that that good relationship hopefully also is beneficial to everybody. There's hardly any myeloma patients that should not be referred anymore, I think, because there's hardly anybody who's not a candidate for CAR-T or bispecific. So I think the most significant barrier is really the perception of new technologies being difficult, and also the perception that we don't go to big center unless something's really wrong. So if they're being referred because they have myeloma, then it's very different comparing to, well, you're gonna go because things aren't going well. I'm from Thailand, so the food that I live with will be Thai food, and I'm thinking I'm gonna loop in Dr. Nuka because I think we're gonna convince him that green curry is actually Thai. But I go to the unhealthy route. I'm gonna go with mango sticky rice.
Oh, very nice. Thank you so much for joining us. Dr. David Siegel.
I think that this past year, somewhere between 150 and 160 commercial therapies. Another. Sure, obviously, mainstays are Vicky, it's still doing some of that as well. But we also have basically what we mentioned, some of the tools that you need for T-cell platforms, to allo or T-cell clinical trials. What's the biggest barrier? Well, I'm going to give a more cynical answer. That internally, there are some issues that come up, but no theme. I think the biggest theme in terms of access is that I'm part of a very large, very dense metropolitan area, and I think the jealousy with which private practice oncologists guard their patients, not wanting them to go to myeloma centers, whether it be ours or other ones in the neighborhood, because they will lose them, and the profitability that goes with the extraordinarily expensive drugs that they get to administer to myeloma patients is by far the biggest barrier to access. That just unless they are smart enough to figure out that those options are out there, that it's hard to get local oncologists to refer until the patient is dying. And so that's that. And my name is Siegel, but I'm half Italian. So mommy did the cooking back then. Mommy doesn't do the cooking now, actually. But so it would be pasta as long as you get to like choose different things to put on top of it. That sort of like saying rice, but
It's the loophole to the question.
yeah,
He says pastas.
I'll take the loophole. But she did come from the Soto part of Italy, so it would be, I could say rice as well.
Okay, sounds great. Thank you so much, Dr. Siegel. You bring up some really great points, which has become even more valid as all of these therapies move earlier lines. So we're really excited to hear what you guys are thinking about that, how you're communicating with the community, because DAVA also works on community programs to educate them on these options. So we'd love y'all's thoughts on how we could best do that. Dr. Jacqueline Rosenblatt.
Hi, I'm Jacqueline Rosenblatt from Beth Israel in Boston. We do about, I would say, 5 to 10 myeloma CARs a month at our center. The trials we have are similar to what's already been mentioned. I will maybe make a pitch for an investigator-initiated trial that we have that I'd love collaborators at just giving a vaccine in the early period after a commercial CAR to try to enhance native immunity. The biggest barrier, I would say, in the early line is both sort of what's been mentioned about getting referrals from the community, but I would say also early line patients' apprehension about the low risk but real risk of delayed neurotoxicity. I've had several patients recently who are apprehensive early on about sort of assuming that risk. And one food I would say probably is ice cream.
Ooh, very nice. Thank you, Dr. Rosenblatt. Dr. Shahzada.
Sandy has made my job very easy now, so it will take very few minutes. I think similar to what Sandy has mentioned about the system is pretty robust and pretty good in terms of taking the patients to the CAR-T, active clinical trials, collaborative team efforts within the group. So this is all great. In terms of barrier, I think there are patient factors as well as the society factors. So for example, frailty, disease progressions, toxicity, especially the delayed neurotoxicity, these are the major ones that I see from the patient side that they decline the CAR-T. Lack of caregiver support, transportation issues, that's another challenging part. Sometimes because of so many clinical trials of CAR-T, not only myeloma, amyloidosis, autoimmune conditions, getting a slot for apheresis and things getting challenging in that area too. So that sometimes delay the timing when these patients get the CAR-T. Now, in terms of the food, as you know, I'm from Indian Pakistani food is my favorite. So some of the people are here from that area as well. I like biryani. If somebody don't know what biryani is, please try that. It's spicy, but you'll love it.
Excellent. Thank you, Dr. Raza. Dr. Isha Malik.
Thank you. I come from Roswell. We 2025, I think we did around 90 BCMA CAR. In terms of trials, so we have GPRC5D CAR single agent. We have GPRC5D CAR with BCMA bispecific consolidation trial. We have AlloCAR and trispecific. We hopefully in the line of the in vivo CAR trial also. So it's a very heavily invested on CAR at Roswell. We are. I think the main problem with patients, they can get CAR. I think nationally half of patients only they have CAR if really they are eligible for first relapse. And I think the main things is this, I would say, business model. We expect the community oncology essentially drop their profit, their business models of continuous therapy of myeloma, and then they send patients, and even patients comes back to them. Patients are not on any therapy. So all these pharmacy nurses they hire, so they can't pay for that. So I think obviously gap in the knowledge, but in Roswell we deal with a very vast referral base, so all sorts of practices I see. But even gap in the knowledge also is not a problem many times. Many times just, they have to pay bills also. So I think that's the main, that how we can overcome that, I don't know, but I think that's the main one. I would say best food, I would say a smoked brisket, a good smoked brisket. That's good to go.
Texas, I can agree. Smoked brisket is excellent. Thank you so much, Dr. Andrew Kin.
Hey, Andrew Kin from Karmanos Cancer Institute in Detroit. Pretty similar in terms of volume, 5 to 10 CAR-T patients a month, I would say. And a bunch of the similar trials. We've had CARTITUDES, anito-cel, AlloCAR trials, and also very happy to have some of the amyloid CAR-Ts as well. I think the biggest barrier at our center, our network, is referral patterns, but our network extends kind of up into the kind of remote and rural parts of Michigan. So one part distance, one part caregiver support, one part Detroit stigma, but one part kind of private practice or awareness or of getting patients in to be evaluated for CAR-T sooner, but getting those patients from the network kind of down into the center for evaluations that many of them certainly would be CAR-T appropriate, I think is probably our biggest challenge. One food for the rest of my life, probably a good steak.
Nice. Thank you, Dr. Kin. Dr. Gurbakhsh.
Okay, so it's hard to ask a New York hospital where nursing was strike on how many patients we've done in the last month. We got just basically, I think, 4 emergent patients through and everybody else had to wait. So we were very much affected by that. And I think everybody sort of on the right side alluded to the trials that are open, AlloCAR, anito-cel, Durga. We have same thing that most of the people in the room already mentioned. So in the essence of time, I'm going to be to the point. So I think the CAR T patients comes in 1 or 2 lines too late. And that may be for all the reasons that have been highlighted, which then creates a barrier for us to safely go through CAR T. And when they come in with explosive disease, knowing that there are delayed neurotoxicities, sometimes that gives patients pause in pursuing it as well. So I think it's just not a single barrier. I guess the single barrier is if they just come in too late. And then there's multiple reasons behind that. And if I could eat only one food, it would be an aloo paratha. I can eat aloo paratha. They're very fattening. I love them. It touches my soul, my mind, everything. It's basically, America knows only naan, but aloo paratha is like a whole wheat sort of Indian crepe, but stuffed with the potato stuffing, with some ginger, coriander, and spices. And I'm not that great of a cook, but if there's one thing I can make really well, that is an aloo paratha, and I can have it every single day. And I made sure my kids love it for every single day as well.
Did the PRA today?
Yeah, paratha. And if it was me, if I left medicine, I will open up a paratha shop. New York City, I'll open up a cart, and I've actually thought about doing it.
Great to have a backup plan. That way, when AI takes over jobs, we have another option. Excellent. Thank you so much, Dr. Carr. Dr. Ishmael Jayasini?
Yeah, thank you very much. Our program a little bit different. Started 3 years ago. It's community independent practice. Not only CAR T for myeloma, for lymphoma and acute ELL too. We've done more than 50 now. The majority of them are multiple myeloma. In a week, maybe we evaluate about 5 to 8 for new CAR T patients, especially for myeloma. The second question, the trial we are contemplating of doing now, we are continuing to do I-need-to-sell consideration of that. We are trying to encourage more clinical trial. In the last few years, because of financial restraint our institution, most of our trials are very, very restricted. The next thing I will ask the question on the single most challenging we face, because we have almost 30 oncologists, hematology in our practice, is the education to know when to send those patients for evaluation. And unfortunately, it has been mentioned already. Many times we keep those patients for multiple lines. By the time they send that patient to me, they're in wheelchair. The functional side is horrible. Significant cytopenia due to massive disease in the marrow, that most of those patients, many times, they are not really candidates. I will say one thing, though. In the last 1 year, with more education, I've seen from my group now, they are sending those patients to us more. As you all know here, early treatment with CAR T has been shown over and over at Comadera. And I think our group know that. In fact, our departmental meeting every month, I try to say something in 5 to 10 minutes, and we share with the department too, just to educate our groups, and also to get all of the craziness of practice that we treat 10 lines, 12 lines. I think we're going to continue getting better for sure. If I have to choose the best food, I'm an African. I love rice, jollof rice. I will eat that every day.
Excellent. Thank you so much for joining us. Dr. Caroline Huff?
So thanks very much. I would say on average, we do about 5 to 10 myeloma CAR Ts a month. We do other diseases as well too, but that's not really within our myeloma group. Trials that have been mentioned, we are between trials at this point in time. We've had challenges with research staffing to open more trials. So that is our biggest limitation, not our interest or desire, just the ability to do so. I think the biggest barrier is really getting patients in. I mean, we have always done all of our CAR Ts as outpatients. So it's, one thing I haven't heard anybody say here is beds, but it's not a bed issue. We can do our phoresis, we can do those aspects, but just getting more patients in to see us earlier on in the process. And food, I struggle. I think I would probably starve, but I'm gonna go for chocolate, so.
One thing I need to mention, we've been doing all our CAR T too. I've been doing that since last year, all outpatient now. And it's been great for the patient and for the family too. Yeah.
Absolutely. Thank you, Dr. Huff. Dr. Riddhi Gupta.
Hi, good morning, everyone. Riddhi Gupta from Montefiore. So we do about 4 to 8 BCMA CAR Ts a month, and we are growing. But as Dr. Carr was saying, because of the strike, we were limited as well last month. We have some of the same trials open, the CARTITUDE trials, Durga trials. We are trying to expand our armamentarium a little bit more, trying to get in vivo CARs as well. One of the biggest challenges, I think, in enrolling patients to CAR T is very similar to everyone else. I think there's a theme. One is the referral patterns from the community. I think they still feel like it's so toxic and patients get sick, and especially our older patients, they won't be able to tolerate it. So I think educating our community and community docs is very important. I think the second is also patient. We deal with a very underserved patient population, and their understanding of this, we're going to modulate your immune system, and we're going to connect you to a machine, and we're going to take out your immune system and then genetically modify them. They still think it's like all, voodoo medicine that we're doing, So I think educating patients is one, and their issues with caregiver support and monitoring. And then we also sit in New York, so we have other giants around us. But so I think that's another challenge for us as well. If I had to eat one food, like everybody else, I would do biryani aloo paranta, but I would also do chicken kebabs. Love them. Thank you.
Thank you so much, Dr. Gupta. Dr. Alfred Garhol.
Hi, good morning, everybody. Al Garfall from Penn. We are similar to other centers in size, so about 10 patients per month, probably typical. Our trials, we have one of the AlloCAR trials open right now, and we're hoping to open one of the upcoming frontline BCMA CAR trials that are going to run in the BMTCTN hopefully sometime this year, and one of the Durga trials as well. In terms of barriers, similar to what others have said, I still think there's probably a whole world of myeloma patients who don't get to us. Even though we have good relationships with our local private practices and our own network, I still feel like we see for a CAR T cell this sort of more sophisticated and motivated half of the myeloma population. There's probably a whole world of patients that don't get to us just because they are presumed to not be interested or thought even at the pre-referral point of contact not to have interest in it. Caregiver support. So we also have been trying to do more and more outpatient, and our hospital is pushing us to do that. But the number one reason why someone has to be inpatient is because they don't have a caregiver to stay with them 24/7. We're comfortable medically with just about anything as an outpatient now, but we can't replace a caregiver. And then I think a medical barrier that I think is the toxicity, and alongside the alternatives like bispecific antibodies that are similar in efficacy without the toxicity. And so that I think in our current practice is a barrier. And in terms of food, I think I would choose something like a hummus and falafel and pita Mediterranean type of thing with a lot of olive oil.
Oh, yes.
Yeah.
Thank you so much, Dr. Garfall. Dr. Kathleen Doherty.
Yeah, I'm Kathy Doherty from UPMC, University of Pittsburgh. We probably, I guess, maybe 5 to 8 BCMA CARs a month on average. Trials similar to what others have mentioned. We had like CARTITUDE trials open, whatnot. We'd love to get a GPRC5D CAR, and we don't have an allo CAR at this time. In terms of the barriers, I would say, we have 70 community sites spread all over Pennsylvania. So some of our sites are 3.5, 4 hours away. So it's definitely not palatable for patients to have to travel that far. And as of now, they do spend at least part of their time in the hospital. So also support for caregivers to stay locally with them. And then there are patients who just don't have a caregiver to monitor them closely after. And then one food, maybe it's my Irish heritage, but I would say potatoes because I like them in all forms. So
I
potatoes.
especially love them sliced thinly and fried.
Yeah.
That's the best. Thank you so much, Dr. Doherty. Dr. Ashford Badros.
Hi, Ashford Badros from University of Maryland. I know we did last year about 19 myeloma patients. We do a mix of inpatient, outpatient. We do have a lot of trials, actually, probably Cartitude, Allo, and we do have an in-house trial that will open. Again, it's a new target called the CD229. And we do have some maintenance trial after CAR-T. The barriers, I think social barriers are actually very significant, especially having a 24-hour caregiver. That's becoming a challenge. Driving every day, having all this issue. And then the hospital limitation, we do have limited number. We can only do 3 to 4 apheresis a week for our patients. So we try to work with that. Food, falafel is where I come from, but I think I would choose pizza probably.
No one, I'm surprised no one said pizza yet, coming all the way around the room.
So it's pizza.
Pizza is always a good choice. Thank you so much, Dr. Badros. Dr. Syed Abbas.
I know, thank you so much. I think at this point I should just cut to the food. So actually, I'm going to start a bit backwards here because this whole time I've been anxious about should I go with chicken, should I go with potatoes? Because I love them both, right? Because if you have to go with chicken biryani, that's great, but I won't have chicken biryani if it doesn't have aloo, potatoes. But if it doesn't have chicken either, I might still have it. So in the end, what I'm going to say is that if I were on a desert island, I wish it'd be someplace I could grow potatoes and hunt jungle fowl, and then I'd be good. I'd be covered for everything. So
jungle fowl.
You see that?
Yeah. Yes, yes, it is. But so coming back to the CAR T cells. So a couple of comments. I think Dr. Badros, everyone here, and Caroline, I agree very much with their points. I will say to David Siegel that one of the biggest headaches that I have is when a patient refuses to go back to their referral oncologist. And I try not to be mean to my patients at all, but I'm like, you really don't need to keep coming to see me. You've had your CARs. Please go back. They don't like me taking food out of their mouths. I certainly don't like doing that. Plus, I have limited capacity. So I think I'll echo one of the major barriers here functionally, especially for us in the DMV area, right, where we have a lot of myeloma because of our demographics, but there are psychosocial barriers, is that, and also because of the way reimbursement works, right? We're obligate users of the outpatient space at Hopkins. That's how the whole system has been designed. And Caroline and others, they're at the forefront of setting this up. But what this means is that if a patient doesn't have a caregiver, which is not uncommon, then that's a significant barrier.
Yeah.
So while I think to address the disparities, offering patients our outpatient bispecific antibodies and outpatient CAR-Ts is very helpful from that point of view. It then creates a separate issue, which is the caregiver issue. So I think that certainly matters. I think it matters for the thought process for referring centers and referring colleagues about, hey, when should I send a patient to you? How quickly can you get them in? And so on. I also think that lately, for patients, the calculus has changed a bit because often enough people come in and say, hey, doc, have you seen this article in the Washington Post about this new magical treatment? And I'm like, the guys at Janssen, they're both the right and the left hand here because you could skip your CAR T cell if you wanted and at some point get what comes out of Majestic 3. But everyone at Janssen J&J would be super happy. But they're like, well, you know what? Should I do the CAR T cells? I love the one and done, but I hear bad things about it.
Yep.
So I think education, both for ourselves, our patients, and our referring colleagues, all of this, and who is appropriate, who should be sent forward. And I think referral to a myeloma center should be universal because these are becoming more and more nuanced, even for us. So these are some of the issues that I think we'll keep facing going forward.
Absolutely. I think that's maybe such an important conversation to also have with the community doctors, because to Dr. Siegel's point, as more of these community doctors are able to give bispecifics and Majestic 3 comes into this play, that's an option that they can give at their site. But we don't necessarily know that that's the best order. If your patient can get CAR-T, you don't want them getting Majestic 3 first. So having those education conversations is so important as all of this comes earlier. But we also have to educate the community to be able to get the bispecifics, or they're going to lose all their myeloma patients entirely because bispecifics have been first line.
And I'm so sorry, just one more quick comment. There is one active trial so Caroline said we're in between trials right now. But an active trial that we have at Hopkins for CAR T cells right now is CD19 CAR T cell in the lupus space. So, and we partner with those guys to help because they don't do this on a daily basis, right? So CD19 BCMA targeted CARs beyond just the myeloma space. So then that will then go on to, yes, more infrastructure issues, more caregiver issues. That number is going to keep growing.
It is. Yep. Thank you so much, Dr. Abbas. And last but certainly not least, Dr. Vinod Dakal.
Hi, good morning, Binod Dakal. So I probably go to the point answer. First question, 50 to 70 CAR T BCMA, partly because we have like other trials. Second question, we have all the trial, what was mentioned. The two I would like to pitch in is two IIT that we're doing. One is in-house CAR against TGF-beta and BCMA. That is first patient getting enrolled next month. Very excited. And other one is AlloCAR against the undisclosed target. So I'm kind of, it's confidential, but I'm very excited about it. That is also in-house CAR. In terms of barrier, I think I agree. I think bispecific use in the community is going to be the major barrier. Right now, I can already see that in the late relapses, the big bispecific group in the community are not being referred because they're using bispecific, and that's going to move in the early line. So referral, timely referral, and the referral from the community is going to be the barrier. And lastly, the food, boring food is rice, but with the rice and lentil, that is very famous in Nepal. So I like that food.
Very nice. Thank you so much, Dr. Dakal. All right, really excited to hear more about everyone's experiences. I'm going to invite Dr. Nuka to come up and kick off our first section. We're going to talk about the latest data for second-line CAR T and multiple myeloma. And would you like to walk around, or do you want to change the podium?
I'll stay here.
Okay, that sounds fun.
It's nice to hear the dietary choices, but as all of us start to think about how to analyze this, the right side has a better survival advantage than the left. So more leaning towards the Mediterranean diet, as Al talked about, decreases the cardiovascular mortality, and nice of how a researcher's mind works. So I'll be talking about the latest data for the second-line CAR T in myeloma. And this is all the data that is new, fresh, coming from ASH. And I'll put it in the right perspective. So this slide doesn't need an introduction to any of us. So what you see here is the overall survival of close to 5 years, the median overall survival of 5 years. And this is the results from the CARTITUDE-1 that was presented at ASCO of 2024. And what we see here is a third of the patients still continue to remain alive after 5 years without any need for any additional therapy. So if you think about who are these patient populations, so have we achieved the target of a cure, and could this be used as a tool? Could cell-to-cell or any CAR T targeting BCMA could be used as a tool to achieve that cure? That is the holy grail for all of us in myeloma. So now moving on to the sandbox. So we talk about the sandbox, and we have established a principle that, yes, the current treatments that we have in terms of the CAR Ts have provided us the ammunition that would achieve that cure. Now, where is the space where we could exploit the most, and who's the patient phenotype that we could avail to get there? So that's going to be the point of my discussion over the next 10 minutes. So let's talk about the CARTITUDE-4. So in the sandbox, in CARTITUDE-1 trial, we have shown that among patients who had seen 5 to 6 prior lines of therapy, heavily refractory patient populations, this is the proof of principle is set in that it's a safer drug despite the toxicities that we see on a daily basis, but the benefits strongly outweigh the risks. And we achieve a significant MRD negativity in earlier lines of therapy, just like how we've done with every single treatment. So if it's so efficacious in the later lines of therapy, can it be more useful in earlier lines of therapy, early relapse, or eventually a newly diagnosed setting? So CARTITUDE-4 evaluated these patients to receive cell-to-cell in the early relapse compared to the standard of care. And what we see is a significant increased rates of MRD negativity. Almost 82% of the patients that received cell-to-cell had an MRD negativity. And more importantly, sustained MRD negativity is seen in a significant proportion of these patients. So now we have the tool to get there. We also have this tool to measure the deepest response. So we never had both these tools in all our lives until now. So now, as we start to define what cure looks like in myeloma, my gut feeling is these tools, both of these of what we're talking about, the CAR-Ts and MRD, are going to be our important measures of getting how to reach that cure as we start to define what cure looks like in myeloma. So in CAR-T4, at the time of the 30-month overall survival, 75% of these patients continue to be alive and doing very well. So now teasing into who are these patient populations. So those patients that are standard risk are the high-risk patients have done much worse compared to those that received standard of care compared to those patients that received cell-to-cell. So now jumping on to talking about, if you think about those standard risk patients, so and if you start to delve into who are those patients that could get the best response. So this is this is a subset analysis that was presented by Luciana Costa at ASH. I'd go a little deeper into this slide sets to talk about what do the standard of care patients achieve with cell-to-cell. So of these close to 415 patients, so 419 patients, standard of care was given to 211 patients, cell-to-cell of 208. And among these patients, standard risk as defined by the protocol, without any presence of high-risk features, without presence of gain or amplification of 1Q, an equal number, around 70 patients were in each arm. And this is the target group that we'll be focusing on. So if from the CARTITUDE-4 trials, 100% of these patients achieved significant response rates, CR rates in 92% of the patients that had the gain of 1Q, and the 30-month PFS for the standard risk patients is significantly higher, favoring the CAR-T. So every subset that we had seen that has evaluated cell-to-cell versus standard of care, there's not even a single subset that showed otherwise. Every subset has favored, if you look at the forest plot, everything is to the right favoring cell-to-cell. So now we're starting to define that phenotype. So number one, we talked about those standard risk patients having achieved a significantly higher response rates with cell-to-cell. So if you look at these curves, the PFS and the overall survival curves, those patients, there is a small slight crossover, as you can see from the overall survival, because the toxicities that Al was talking about before. So if you look at those patients that are alive more than 1 year, standard risk patients alive more than 1 year, their overall survival outcomes are significantly better. If you can look at the 4-year overall survival, almost 94% of these patients continue to be alive. So those patients that had standard risk disease, those patients that are alive at 1 year, continue to derive those benefits as we continue to go. So how about the toxicities? Just delving deeply into this, the non-relapse mortalities in this patient population is around 10%. And if you start to look at this, most of these reasons, these are preventable reasons. So I'll go through with each of these. This happened in COVID-19. So right now, I don't think it's a problem. So in the past, when we were designing any of these trials, we never had the supportive care because we never were anticipating these toxicities when we're targeting BCMA, never incorporated IVIG into our treatment algorithms. Now we don't see infections to be a major issue that are causing the death. Think about subdural hematoma. The cytopenias, unlike what you see with the transplant, where it is very predictable, it takes its own sweet time up to the 2 to 3 month mark. When we saw the first subdural hematoma in our patients, what we started to do is to use salvage stem cell boosts very earlier on, within that 45 to 60-day mark, so that we're able to get those counts very, very quickly, and we're minimizing these toxicities. So 2 deaths beyond the first year, the gastric adenocarcinoma, angiosarcoma, these are not the most common ones associated with secondary primary malignancies. So I'll take it with a grain of salt, how much these are related to the T cells. And the SPMs of close to 13%. And there is no hematological toxicities or the hematological SPMs that one had seen here. These are cutaneous invasive or non-invasive SPMs. So overall, the toxicity profile doesn't make me wince when I'm offering a CAR-T, when I show this slide and explain each of those to the patients. So as we see, we define the standard risk patients. We define those patients who continue to be alive beyond that 1 year mark. I want my patient to be on that top curve at the 1 year mark, who at the 94% overall survival. So when you start to tease down, so those patients that were in the CARTITUDE-4 by the lines of therapy, and by even in CARTITUDE-4 and CARTITUDE-1, a combination of these three, the patients who got the best benefit are the ones who had early CAR-T. So this goes back to the same thing that Gurbaksh was talking about, Al was talking about. If these referrals could be sent very earlier on, these patients could be right on this top curve. So if you're offering these patients very earlier on, if only we don't have that nursing strike, Gurbaksh. Okay. So moving on to the correlatives, is it all speculative or is there science backing it? So in terms of the lines of therapy. So this is where Samir has presented a beautiful analysis. I'll walk you through these slides. So Samir Parekh got these 134 samples from CARTITUDE-4 and 133 samples from, again, from the bone marrow at the day 28 and at 6 months. And they started to look at the tumor microenvironment. Fascinating results, as one can see, how these are associated by the lines of therapy and who have the best tumor microenvironment that could predict for the long-term outcomes. And what you see here is the neutrophil degranulation and increased tumor-associated macrophages. These were all significantly higher compared to the baseline, suggesting a heightened inflammatory state. If you look at these two pathways, the IL-12 pathway, which suggests the M1 macrophages, which are tumor-associated, so significant increase compared to the day 28, but the M2 macrophages are not the ones that are significantly higher. So this clearly is talking about what you see this increase is likely tumor-associated. And similarly, when we talk about these the pathways, the T cell receptor, the cytotoxic lymphocytes, or the MHC1, 2 pathways, so you're significantly seeing this increase as we continue to as we see these patients at day 28 and the 6-month mark. So what they were also able to show was that the patients who achieved a long-term durable remissions. So this is a small number. These are 9 patients. So what they were able to show is they could predict who these long-term survivors are, who had this PFS beyond that 5-year mark, based on the initial baseline and the day 28 samplings from these clonal expansion, the endogenous clonal expansion of these CD4 memory T cells from the baseline to day 28. They're also able to show that the T cell repertoire diversity in the endogenous T cells is significantly higher among those patients that had a PFS of greater than 5 years versus those patients that had a PFS of less than 5 years. So clearly, it boils down to the tumor microenvironment and establishing that immunocompetent tumor microenvironment, which could be seen in the early lines of therapy when the patients are given when they have not been exposed to significant amounts of prior therapies, and a more immunocompetent tumor microenvironment at baseline is seen as earlier lines of therapy that could translate into a long-term survival benefit. And this was clearly seen. The baseline TME, both in the coactivation molecules, the co-stimulatory molecules, if you can see everything, these are all more preserved in these patients that had 1 prior lines of therapy compared to the later lines of therapy. So on the contrary, they started to see what are the hostile tumor microenvironment that one can see. And this is the patients who had the shorter PFS, less than 18 months. And these patients had higher Tregs. There's the EMT signatures and the PI3 kinase pathways. These are significantly adverse in compared to those patients that had longer PFS. So beautiful analysis supporting usage of these CAR-Ts as earlier lines of therapy. And this is a simple analysis that they looked at PFS stratified by the CD4 naive cells at baseline, and they were able to clearly show a PFS benefit. And these CD4 naive cells are significantly enriched among those patients who had one prior line of therapy compared to 2, compared to 3. And the baseline or the bottom line is these patients who receive the CAR-T as earlier lines of therapy have better baseline tumor microenvironment that could predict the long-term outcomes. So these CAR-Ts, as we had seen, had provided durable remissions among heavily refractory patient populations. We could use the technology in the early lines of therapy to get much, much better outcomes in terms of achieving that cure. So if you think about the data that I presented, both the clinical data from CARTITUDE-4 and the correlative science, all of them supporting the usage very earlier in the course. And I'll stop here and hand it over to Dr. Galloway.
All right, well, we'll jump right into the conversation. And, I think this space is so interesting. When we did these programs even 3 or 4 months ago, conversation was all around risk stratification. Who's high risk, who needs to get early CAR-T. But now we've seen data in standard risk patients, we're seeing this rationale with tumor microenvironment. It's all very compelling. So I want to hear what you guys think. Is this still a risk conversation, or should everyone be aiming for early CAR-T?
The main challenge in this model is difficult to predict in the clinic how to identify these patients, right? That is the biggest unmet area where we need to think about. Even when we talk about T cell fitness, how to measure that and how to apply that in the clinic, we have no idea. So that is a problem. And you are looking at the observation once you have the effect already. So to find out how these patients do a priori, we know we have some clinical, we're going to talk about next. There are clinical markers at your hand. But if you look at CARTITUDE-1 data, that the long-term survivor, if you look at the clinical characteristics of those patients, they did have EMD, they did have high-risk markers. So even despite that, these patients were able to achieve more than 5 years. So at this point in time, it's very, very kind of complicated, to have some prediction model, at least based on this analysis. And there are some clinical factors that you can say that these patients don't do well, like EMD for sure, some high-risk abnormalities, high disease burden. But beyond that, it's I would say still a lot of work needs to be done. And again, this is a limitation in doing the microenvironment analysis without looking at the microenvironment in totality. You're looking at a specific aspect of each individual cell line and trying to say that this is what it happens. But I'm not sure how we can apply this in the practice.
Then I can push back.
Yes, please.
So it's almost impossible for us to use any of these to make a treatment decision.
Exactly.
Yeah.
So the way that I'm putting this is the data should be construed in a way, what are the surrogates that one can see by using this data? So if we saw a clinical improvement and we're supporting with a correlative analysis. So the surrogate here is patients who had seen 1 prior line of therapy had better microenvironment than 3 prior lines of therapy. If I had a choice to use CAR-T, I would want to use it in the first line of therapy. Am I saying it wrong?
No, I think, sorry. You make a really good point. Ideally, we would want our patients to get CAR-T after that first line. In reality, patients see us 1 line too late. So our own patients who are within our practice, those discussions start early. Patients who are coming from the community, they're already 2 lines and beyond. And I think more and more recently, at least in my clinical practice, the patients who are just after 1 line of therapy, those discussions, because those are very highly motivated patients if they get to you at that point.
Yep.
And the discussion was a lot on toxicity. I've had more patients who've given me pushback and actually had anxiety and meltdowns once they find out about the Parkinsonism and they find out about delayed onset of GBS, because that's what they see and that's what they read and that's what we have to educate about, and the hematological malignancies. I've had 3 patients who said, I cannot make this decision right now. Luckily, they have slow growing disease, and that's exactly the type of patient you want to take to this CAR-T because they're bound to have good outcomes. They have low burden of disease. They're going to possibly the patients who we may call cure. I don't know. That word is very tricky for me, but we get a lot of, unless the toxicity piece gets more teased out, what to do, how to intervene, that population gets tricky to treat.
That's so important. And we definitely want to have the toxicity conversation. We're going to do it in the whole second half for sure, because that is an incredibly big piece of the story.
If I may say, just to follow up here, we were talking about this yesterday about who can we predict will end up in a a deep remission state or an MGUS-like state, right? And there's no way for us to know, as you were saying, except after the fact. I only have time to tell me one way or the other. I have some markers, right? If you fail to get into remission with an excellent quad, right? Or if you have start progressing when you have a break off your quad, then things are probably going to go bad. But this is the best surrogate that I have. I would like to go with CAR T cells earlier, but the patient's concerns about, look, doc, I'm aware that the mortality is up to 10% versus the transplant that we did, which was 1% or less at a large institution. Why would I do this? Especially if my myeloma has been so slow growing. If we have patients who show up 10 years off treatment with a slow relapse now, like, do I really need to take on a 10% mortality risk? But then you can have that conversation and say, look, what are your goals, right? How motivated is the patient? Is this a one and done or not? I would love to have that tool that say, you will do well or you will not do well. Let's go ahead and do it. But right now, especially with the fact that the toxicities and the risks are, patients are savvy, they're aware of it. The uptake is not as high amongst patients themselves that I would have thought. The other reason that I prefer to go earlier is because if I need site reduction in between, I have a lot of options that are relatively non-toxic rather than if you wait till the later lines.
Oh, go ahead, Dr. Siegel.
So I preface what I'm going to say with, I don't object to CAR T cells moving earlier, but this kind of comparison that is being made by companies who have these kinds of products, the overall survival, the progression-free survival after a second-line CAR T cell is better than after a fourth, fifth, sixth-line CAR T cell. But that's an unfair comparison. Those patients who are in fourth, fifth, sixth line have already had 4, 5, 6 years head start to get there. So none of these evaluations have taken into account that lag time. And most myeloma patients, and certainly the good risk myeloma patients, who as we said, we can't really identify prospectively, they're not going to die from myeloma. The overwhelming majority of our patients today are not going to die from myeloma. So that 10% toxicity and early death figure that we use is very likely wrong, that we can do better jobs. But the reality of it is you can't kill a newly diagnosed, you can't kill a second-line myeloma patient because they weren't destined to die from their myeloma. So until we get a better handle on controlling those toxicities, and most of those toxicities can be controlled if you treat them earlier, because most of the toxicities are associated with the burden of disease as they come into the CAR T cell. So again, I'm not arguing against it, but we have to be very, very careful as we move into frontline, and certainly as we move into smoldering myeloma, to apply these therapies that have a real mortality rate associated with them. Fludarabine is a horrible drug. The secondary malignancies that come from fludarabine, now we're not using that much of it, but talked about those cancers. Those aren't the kind of secondary cancers that we get, but they are the kinds of cancers that we get when we immunocompromise people, and that's exactly what we're doing. So the discussion is to some extent a little disingenuous because we're ignoring very obvious statistical things and ignoring the fact that we already can have these patients die from their heart disease at age 87, and so what risks are we willing to take? So it's a complicated conversation more than just, okay, we could do a little bit better if we moved it earlier.
So, David, if we go back to talking about by the lines of therapy, last year should be presented. So, agree. So, line of therapy 1 is going to do better than line of therapy 2. So, however, this is a randomized controlled trial. So, and if you look at by the lines of therapy, patients who got a CAR T with 1 prior line of therapy versus the standard of care 1 line of therapy have done, that difference is so significant compared to those patients that got the second line with a comparator. So this.
Oh, again, you're talking primarily about progression-free survival, and progression-free survival in early therapeutic platforms isn't the be all and end all, which is the ridiculousness of the IRODs, all these things that say, look how much better my progression-free survival is in front line. Well, they don't take into account that the patient's still not going to die from their disease. So, the toxicity issue is an enormous issue. And like I said, you're not allowed to kill a newly diagnosed myeloma patient. When I started, I mean, that was never the objective, but death as a consequence of your therapy was acceptable because the median survival for a patient who required therapy for myeloma was 18 months. It's not, now it's 18 years and perhaps longer than that. So, again, the progression-free survival endpoints, those, it's a truly disingenuous conversation. Would I use CAR T cells in those situations? Yeah, I would. But that's our job is to think about all of these things.
And I second a lot of your comments, except I would also add that I don't think that these toxicities are as modifiable as we think. I think we elude ourselves into thinking we have control. I agree, low disease burden is better, but I've had patients get these awful toxicities where I've done everything right, I feel like, and they've done everything, and they've responded well to their bridging therapy and had low disease burden. I also don't think you can say in a subgroup of 60 patients that toxicities that we measure at frequencies of 1% and 2%, that they just are not going to happen because they didn't happen in 60 carefully selected trial patients as opposed to in the real world, even in that early line of therapy setting. I also don't think I would feel more compelled to do this early if I was convinced that with long-term follow-up, there's some real kind of special plateau happening in that one prior line of therapy patient, but there's really actually not. I mean, and this is we all have to acknowledge a little bit the disappointment. I mean, these are amazing results, but at the same time, I think a lot of us thought with those results in 6 prior lines of therapy in CARTITUDE-1 that we would see really nobody progressing when we use these in early lines of therapy. But actually, if you look a few years out, this curve, the PFS curves you presented, there still seems to be a continuous risk of relapse. The numbers look great. They look, better than virtually any other myeloma therapy we've had. So I don't want to discount the efficacy, but I don't think there is a magic to using these in first line of therapy that's just going to erase the disease the way a lot of us thought they would, transposing from the CARTITUDE-1 results to the frontline results. So I think even before MajesTEC-3, I think the data did not support using second-line CAR T cells in most patients based on the balance of efficacy and risk, at least with this particular product. And then I think when you throw in the data from MajesTEC-3, it even further, I think, makes it difficult to justify taking that risk in a second-line therapy patient. I really think you have to, if somebody gets one of these awful toxicities, you have to be able to look them in the eye and say, that risk that you took to get this there was no other option, right? That couldn't have given you similar survival. Actually, your results that you saw, indistinguishable overall survival curves, maybe a tiny little bit of hair difference between 1 and 2 prior lines of therapy, when that second prior line of therapy could have been patient could have been taking on that risk 3 or 4 years later in their course with the disease because they got DKD for 2 or 3 years beforehand. I think that actually makes the point that you can save this to third line of therapy and the patients will do just fine.
So, yeah. I mean, I think I echo something that I agree with almost everything that everyone has said. I think there's a charm. There's, to debate this, I think there's a charm in a one and done sort of a intervention, especially for patients who, can't come in all the time. I think, however, till the time there is a toxicity aspect for it, and I think till the time we are not able to predict it very well, what patients are going to get it, what patients are not going to get it. Right now, it's all surrogate, right? It's your ALC, your burden of disease. But truth be told, I don't think we take patients with an M spike of 5 to CAR T anymore, right? But these patients still develop your toxicities. They still die of IEC. right? They still have cranial nerve palsies or delayed neurotoxicities. So I think till the time we are not able to develop these models of prediction of who's going to develop toxicity or not, I think early on or later on, I think we can't have a good risk versus benefit discussion, I feel, because as everyone is saying, toxicity is real. And, patients who come in fifth line are very different, like Dr. Siegel was saying. They're very different. They're non-producers. They have a lot more extramedullary disease than patients who come in first line, right? And talking about like Majestic 3 coming in or bispecifics and, the tumor microenvironment, I think what we need to know and understand is, and maybe we haven't looked into this as much, is that, which of our myeloma drugs truly affect the tumor microenvironment, right? We don't know that, right? What we know is that your disease, fifth line, is going to be very different from your disease. It's more naive, right? That's something that we know, but we don't know which of our therapies actually affect the tumor microenvironment that even when we consider sequencing, except for maybe the use of bispecifics, we know that they affect the tumor microenvironment and make it exhausts your immune system. So I think we need that information too before we kind of talk about sequencing or take that into consideration.
Riti, so nobody is debating that CAR-Ts are highly effective as later lines of therapy. So we all agree on that. So there, the risk-benefit ratio is well accepted. So the question is all boiling down to, so is the risk worth the benefit as earlier lines of therapy? Right. So if there's a model that would show that you take this patient phenotype and this risk is X in terms of the toxicity, this risk is X in terms of the secondary primary malignancy and so on, all the toxicities. So would that help to change your mind? So that patient who has high risk, you want to offer something else other than CAR-T?
In earlier line, probably.
It's only about we're focusing only on earlier lines of therapy.
I think I would consider it, absolutely. And it'll be a good talking point to patients. Like when we're taking patients to allo transplants too, we have our different models and we can tell them, okay, this patient's is going to be a higher risk for toxicity with a high HCTCI score. So we'll always think about, okay, what else we can do. And especially in earlier lines, I feel, because we have so many more options that we can offer our patients.
So I would just say, I think that the points that were just pointed out are really, really very cogent. As Al Garfal was saying, that having a patient, and as David and everyone has pointed out, having a patient who would otherwise do fabulously well, have a long lifespan, then develop, die, that would awful, right? But even if you have a patient who is otherwise, say, 60 years old, recently diagnosed myeloma, or several years ago now at first relapse, right? And you reduce their disease burden and you see a toxicity pop up, palsies, Parkinsonism, and you're not quite sure why. So the bang really has to be worth the buck. I think you'll find, I thought, and many other of our colleagues thought that they would be using more early line CAR T cell, and I'm using less of it than I thought I would be. So if you can tell me that, hey, look, you have a patient for whom you can get toxicity X, Y, or Z, then that's certainly a conversation to have. But I think there are some patients who are no-brainers for early line CAR T cell, right? Say someone who has rapidly progressive disease, early relapse, and so on. These are no-brainers. The risk versus benefit
Progressing are probably not the right patient for, right? So that's if you look at the CAR T for patient population.
But if you have a first relapse, rapidly progressing, the thing I would do is I'd say, okay, let's say high risk disease, did not get good remission before and after transplant. They're progressing now. I would collect cells, give them cycle-based treatment, produce.
So on the counterpoint, the way the field is evolving with using quad therapy upfront, and almost all patients are CD38 exposed patients. Let's say a patient goes to second line and going to Ajay's point, are you considering something else like versus CAR T in those second line patient populations? So that's something that we have to discuss, right? Because those studies were done when if you look at it, all these triple class exposed patients, even Majestic 3 most of them are data sensitive patient, right? Now, when you have second line patient who is already quad exposed and perhaps they are relapsing early after quad exposure, which one you choose versus CAR T? That is the question we don't know, and that's something that I struggle now in the clinic. And my gut feeling is that we should offer CAR T to these patients because of the fact that how it has shown the benefit in the late line patient, because late line is everybody is triple class exposed.
Absolutely.
And definitely CAR T was superior amongst available therapies. So I think the field is, moving so fast that we cannot make that decision of one versus another therapy as you move forward in the lives?
Absolutely.
It's very much.
We do have an investigator bias with all of us. So the bias is, like I've explained, so we see patients in our clinics who are living very, very long. So we expect every patient to do the same. Unfortunately, what you see in the data, you ignore that. So basically, this data is comparing patients, the same exact patient population, who got a CAR T versus who got standard of care.
Yeah.
And you see an overall survival disadvantage in patients who got this standard of care. So,
But those patients didn't have access to CAR T cells as next line of therapy.
It's not fair, though.
This is a great transition to talk about how we're predicting risk in the quad era. Because so far, all of our risk things have been for patients who haven't been getting quads. Dr. DeCole is going to present some data from
Yeah, I think this will be a continuation of the discussion. These slides will be. So I'll just briefly summarize the slides for next 5-10 minutes, and maybe we can discuss the whole because this all incorporates the discussion that we're having. So basically, I mean, the way you discussed about CAR T is great, and there are some subset of patients who really do very well with the CAR T, but there are majority subsets, like out of 33%, 70, 69%, 67% didn't do well. I mean, well means not less than 5 years. So how to identify these patients in the clinic, and perhaps we can have some kind of strategies to augment or thereby improve the efficacy in those patients. And that we know these are the patients in the clinic. You have some characteristics that that this patient is not going to do well. But of course, at the time, we don't have any other tools to offer besides the CAR T or some kind of a effective immunotherapy. So there have been some recent retrospective and even prospective studies that have been done to identify these patients. One is to look at high-risk patients. So high-risk means not genomic high-risk only, but the high-risk patients mean those patients who don't do well with this therapy, including CAR T. As you all know, the IMS-IMWG has trying to make this definition more uniform, which is better for the clinical trial purposes. But at the same time, we also have to understand the limitation that this is not going to inclusive of all high risk, because there are so many other unknown areas that we don't know in the clinic, or even with this criteria that we identify these patients as high risk. This is one on the left side. You see this IMS-IMWG criteria, which we all know there are 3 genomic features, and there is 1 non-genomic feature that is at the time of diagnosis. And what are the implications of this at the time of relapse? We don't know that as well, but there are some studies showing that these do have impact on the outcome in the relapse patient as well. But more importantly, there are some other high-risk features which kind of really makes kind of these patients, kind of as an unmet need. One is functional high risk, and I'm going to talk about what functional high risk means in the setting of the quadruplet therapy. There are, of course, a high tumor burden patients who really don't do well, even CARTITUDE-1. If you look at it, there are 3 groups which didn't do well in terms of longer PFS benefit. Are the EMD patients, high disease burden patients, especially with the high plasma cell marrow burden. And there is dynamic high risk feature, which more and more we are identifying this as a high risk because everybody is looking at the MRD, and MRD seems to be one of the very surrogate, dynamic risk features. Now, this is the data from US Immunotherapy Consortium. Something to just mention here is they looked at almost 800 patients that are treated with CAR T across different centers. Of course, there is a lot of heterogeneity and type of patients that are used, but that gives some kind of idea about how these patients do and what are the factors that could predict the patients not going to do well with the CAR T. So they are uniformly treated with cilta-cel, and out of 786 patients, you can see the proportion of high-risk patients. So when I say high-risk patients, they are genomic high-risk patients. So that is based on the old definition. There are IMS, IMWG high-risk definition patients. There is functional high-risk patients. There are EMD patients, and there are patients with 1 or more high-risk chromosome abnormalities. You can see the proportion. But of course, there is overlap between these features. You could argue that the EMD patients are not included in the high-risk definition. Why? But some of the EMD patients may have those high-risk features. At the same time, you can see there is overlap as well. And perhaps that is the reason that IMS, IMWG incorporated these main features that would include these other high-risk patients as well. Now here the functional high risk is defined as less than 18 months of relapse after initial therapy. Now you clearly see that these patients with these features definitely have inferior overall responses and inferior deeper responses compared to the non-high risk features, right? So it's some of them are statistically significant, some of them are not, but this is not the adjusted analysis, but you can clearly see that these patients don't have deep responses compared to the non-high risk features, and that might be the reason these responses don't last that long. And similarly, if you look at the survival, whether it's overall survival, or the PFS, that is definitely inferior when compared to the non-features. Like, for example, 12-month overall survival in each of these high-risk features you can see is much less compared to the patients with having not of these features. So this is something that you we could at least identify in the clinic. But unfortunately, I mean, right now there is no any other strategy that we can do. Is so much of variability in the practice. For example, I have done bispecific consolidation in these patients. I have done bispecific maintenance in these patients, bispecific bridging before the CAR, and all those various strategies that has been adopted. Now, I think this is my favorite kind of topic, is how to identify these functional high-risk patients in the setting of quad therapy. So this is the analysis that we did as part of the COMMIT consortium, and Luciana and I discussed about this for a long time, because functional high-risk definition was so much kind of vague even before, because some say 12 months after initial therapy is functional high-risk, some say 18 months, some say 3 years after triplet transplant maintenance is high risk. But what is really high risk, functional high risk in the setting of the quad therapy once you have this? Because quad is now widespread implementation, and in the setting of that is 12 months, is 24 months, is 36 months is a high risk. So high risk in the setting of functional high risk is defined as somebody who had a median survival of 2 years after the post progression, after you have a relapse. So based on that, we looked at our patients. This is about 310 patients, newly diagnosed myeloma, kind of treated uniformly. 117 patients were treated with the Master 1 protocol, which is DERA-KRD, transplant, and then consolidation plus minus maintenance if they are MRD. If they are 2 consecutive MRD negative, they stop the treatment. Then in 193 patients treated uniformly with a similar approach, but not with DERA-KRD, but DERA-VRD. So there are 310 patients total. And what we looked at in this study, we looked at the cumulative incidence of progression at different time points. So the landmark analysis, 12, 18, 24, and 36 months. And then look at after each relapse or each progression, we look at the subsequent outcomes, whether it is subsequent response, PFS, response to different type of agents, and try to identify a kind of a time point that tells us how the survival is going to be, and try to identify or define thereof the high risk or functional high risk patients in the setting of quad exposure. And what we found out, I didn't show you the slide of 12 and 18 months, but this is at 36 months seemed to be the correct time point, because at 36 months, the median overall survival after that is about 2 years. This is the way that we define the functional high risk. So our recommendation, or our kind of a conclusion from that paper is that 36 months relapse after quad exposure has to be treated as high risk. Now you can see the median PFS for the second PFS is 5.8 months in patients who relapse within 36 months. And more importantly, if you look at the overall survival is 23.8 months, so less than 2 years. Now, then we look at the outcome of subsequent therapies on that high-risk patients. Now, very clearly, you see the patients who received T-cell redirected therapy. We didn't differentiate between the CAR-T for bispecific antibodies, but those who received T-cell redirected therapy, they definitely have superior outcomes in terms of both second PFS and OS compared to the non-T-cell based therapy. So clearly, the T-cell therapy has an advantage in the functional high-risk patients, and we have seen that in CARTITUDE-4 subset analysis and CARTITUDE-2B cohort and even the KarMMa-2B cohort. So clearly, T-cell based therapy was superior. Now, this is, I think, was very interesting. This is the analysis before we have a readout of MajesTEC-3. Now, if you look at the adjusted analysis and look at the second PFS in TCRT in second-line therapy, their hazard ratio is 0.17. And it was quite a coincidence when you see the MajesTEC-3 hazard ratio is 0.17. That means if you have a functional high-risk patients and use a T-cell based therapy compared to other therapies with non-T-cell based therapy, you really have a better outcome compared to that. So it's clearly makes a case of using this therapy for this patient. So what we did in this study was define what is high risk, functional high risk for quad setting, and what probably the next best therapy once they relapse. So clearly 36-month and T-cell based therapy. All right, so this is the summary. High risk features have worse outcomes, whether it's IMWG or other functional high risk or EMD. PF for functional high risk in the setting of quad, it is less than 3 years. And for second line, T-cell based therapy seem to have a better outcomes in these patients. Now, there are a lot of studies that are being done in these high risk settings. There used to be a study called KarMMa-4, unfortunately, that was closed, which looked at dedicated high risk patients, but they are conventional high risk patients. Similarly, we have CARTITUDE-5 and CARTITUDE-6, which has completed the enrollment. We have to see how these patients did in a subset analysis. They are not all high risk; they are all comers. But that data will help us decide, what is the benefit of the T-cell based therapy in these high risk subgroups. Now, other area, which of course we don't really look into much, is the frailty. I mean, frailty is an eyeball test in my clinic. I don't do any kind of objective way to look at the frailty, but there, of course, plays an important role, and multiple studies have shown that in any therapy for that matter, frailty does, play a role. And this is the study that was done to looking at the frailty and their outcomes, the patient outcomes with the T-cell based therapy, especially the CAR T therapy. This is the CIBMTR data. Large number of patients, there are frail patients, and they compare the outcomes of non-frail patients. The frailty is defined here by simplified frailty index, mainly looking at three things: age, comorbidities, and performance status. And those three things, they define the patient as frail. There are 183 patients. You can see the disease characteristics. They're pretty kind of a standard. There is nothing difference in terms of disease baseline characteristics, and they received cell-to-cell. Now, one third of the patients, but of course their ECOG performance status was worse there compared to the non-frail patients, and they have a little bit more progressive disease. Now here, if you see the responses is probably comparable between the frail and non-frail patients, but what impacted was the outcomes in terms of progression-free survival and overall survival, so they don't do well as non-frail patients. At 12-month PFS was 62.7% in frail versus 75.9%. Similarly, overall survival is 70 to 8% at 12 months versus 90.4%. So this is clearly does play a role. And when you look at that in adjusted analysis, these patients don't do well in terms of CRS and ICANS. Their risk of the CRS, ICANS, and prolonged cytopenia is much worse than the non-frail patients. So that probably could be one of the reasons that PFS goes down. And when it did this adjusted analysis, frailty acts as an independent predictor for PFS and OS. Your PFS, OS, and all grade ICANS. Honestly, the oldest patient I have transplanted, I have given CAR Ts, 88-year-old lady. She was very fit at baseline. I did the talc bridging, really did the debulking before the CAR. She's right now 15 months out cell to cell. But I have not done a lot of older patients, but definitely frailty in terms of performance status, and when you look at the disease burden and comorbidity, that definitely does play a role in the outcomes of these patients. And age by itself is probably don't play a big role, in the practice. So this is the summary. Cell definitely is very effective, but when you look at the frail patients, they don't do the same bang for a buck compared to non-frail patients. So definitely identifying the right patients and then offering this therapy to these patients is critical. And at least for these patients now, we have bispecific antibody that really is much easier to give, in my opinion. The question that we discussed about how that would impact once you have the bispecific coming in the early line, and we already saw the Majestic-3 data, which looks quite impressive. And there are a lot of other studies. You will have a readout of Majestic-9 that is not it is an early line, but they're all triple class exposed patients. There will Monumental-3, Monumental-6 data will read out. Similarly, we also had some glimpse of Majestic-5 where they're using this bispecific combination in the frontline setting, and really see impressive responses. So you really have to see how this data will pan out and compare to the CAR T, and of course in the setting of the readout of CARTITUDE-5 and CARTITUDE-6. So with that.
May I challenge you before you sit? So why functional high-risk definition is relevant to quadrant when it seems like CAR T, in the era of CAR T, we may have different risk categorization. When you have a CARTITUDE-1, when you divide patients that they relapse less than 5 years versus patients they relapse after 5 years, or they didn't relapse after 5 years, you have high-risk cytogenetic the same in both groups, right? So it tells me, I think it should be defined later, but it tells me, I think in the era of CAR T-cell, the risk categorization that we do is not valid anymore, right? It may be like that. So that functional high risk, let's say, even patients after transplant, they relapse fast, we're going to put them on CAR T-cell anyhow, regardless of functional high risk or not.
So number one, I think in my understanding, functional high risk is our lack of understanding the biology at the outset. That's one, right? Number two, despite that, there might be small subset of patients where we probably don't know anything about the disease biology at the outset, even with the best tool, but they still do relapse early. Means that tells you that probably something happens as they go through the treatment. But this analysis is done in the context of quad therapy, and I agree. I think at the immediate second line right now, what to do for those patients, that is not clear, right? I know the T-cell based therapy is better, that's the data has shown, but there are a lot of other options. So what that tells you is that for the functional high risk patients, what is the optimal time point that you you say this is the functional high risk in the setting of quad therapy. That was never defined before. And people always question, right? Somebody relapsing after 4 years versus somebody relapsing after 3 years. That tells you that why it is important to define that and then perhaps encourage to get them the T-cell based therapy, whether it's a CAR T or bispecific antibodies. I mean, when you have a data from the CAR-T5 and CAR-T6, and that might be a different definition of functional high risk down the road, right? So that will evolving target. But in the context of quad exposure, I think this is what probably is the most data we have.
In terms of I may have missed that methodology of what you've done. So how many of those patients that are qualified for the IMS, IMWG, the Venn diagram of how many fit the FHR36?
In the definition of high risk, we didn't look into that. So what we looked at is independent of the high risk. We didn't look at what the biological risk was before. We just looked at the patient who progressed at different time points. And then the number if you look at that exact number, there is about less than 1/3 of the patients who had the IMS, IMWG high risk.
Because if you look at your odds ratios, they're almost similar. So IMS, IMWG high risk and your FHR36, the odds ratios are exactly similar.
Yeah, but the numbers was much higher. There is only 1/3 of those patients.
So how much is the overlap is what it was?
So 1/3, 30% of the patients had IMS, IMWG defined high risk, when you go back and look at those high risk.
It really just highlights that there's something else that we're not being able to pick yet.
Yeah, there is a data that the group from Martin Kaiser, they looked at that in their prospective study, in the Optimum study, and they clearly saw that there are about 30% of patients where you try to define their high risk at the time of diagnosis with the biological features, but they won't be able to tell it, and they still do it. But that number goes smaller and smaller once you have to use better tools.
Yeah, there's just a paper called questioning the value of functional high risk because if you look close enough at the genetic,
the number goes smaller and smaller. It's like it's like a non-secretory disease, right? Once you have a light chain free assay, then number went down. The non-secretory disease, right?
I just want to mention one thing. I think the high risk definition in this particular cohort is a little bit deceiving because you excluded a lot of patients that actually progress before they get the CAR T cells.
So you're talking about the
real world experience. And the other thing is, the real functional high risk that's excluded from all trials is the patient that we see with plasma cell leukemia, who relapses within 6 months of transplant with extramedullary disease. I can tell you that those patients do not benefit from CAR T, irrespective of how you do it and what you give to get them a remission. So I think really high risk patients are still, if I can say that, unmet need. I think Ajay showed us data about standard risk patients. We got it. If you're standard risk and first line, you do great. I think all of us are waiting to see if you do CAR T upfront, will your outcome be better than doing quadruplet followed by transplant?
No, I mean,
I think if we can step a little bit to the lymphoma group that compared R-CHOP versus transplant, as you know, there is no difference in survival, at least until now in the first Zuma trials. So we might be dealing with the same in myeloma. You're curing subset of patients that will be cured, whatever you give them, even without transplant, and then you end up with the real difficult patient that are difficult to cure. And I think if I have to focus with a patient, this is a group of patients that we would like to
but the question is
molecularly and clinically, and they are challenging.
No, the question that comes is, yes, they don't do well, but what are the other alternatives that will do better for this patient? There's no other alternative, right?
Let me tell you something. I was following a patient for 3 years after transplant, after CAR T, and she's first line. The patient started having shortness of breath, cardiac workup, all that. And then to my shock, she came to the emergency room with massive pericardial effusion, pleural plaques, as well as pericardial plaques, biopsy-proven plasmacytoma. I don't know when this developed. I gave her 3 years remission, nothing happening in the blood, and we're taking bone marrow every year. And she's developing this very unusual presentation. So the other thing that we have to pay attention to is what form of relapse you're going to be dealing with. I can assure you that a lot of patients are relapsing with various forms of disease before we pick it up clinically. And that lag time adds to, I think, what we are describing. How much lag time are you dealing with?
How are you treating the patient, Ashraf?
She's in deep trouble. No, but I mean, what are you going to offer a patient? We're giving her talquetamab and we are adding daratumumab and we're trying to see if we can control it. But as you probably know, this patient has probably very poor outcome.
I think the pattern of relapse do change, even with the CD38 monoclonal antibodies too. Numbers are normal, EMDs and things are happening. I do have a problem with this whole data that has been presented here. Because whenever we do the real world analysis, I mean, I've been a part of those papers too, but I can tell you, there is always a problem when you do back correlative analysis, regression models, when you do not have a pre-specified endpoints, and then trying to, you can make it in a way that it's appealing, but a lot of retrospective data. But that's not a debate here. I think my major question is the lines of therapies, and I think what Ajay was mentioning it before. See, the lines of therapy concept is a big problematic. VD, RD, first trial, I've been from that era, so I can tell you this is how you used to do that. Doublets and the triplets comes in, and still there is a practice. I think when decision of CAR T is being made or T-cell engineering, it's important that we know the class refractoriness. And I think this has been presented many times, but I think this is a concept that needs to be revisited in the clinical trial setting, although FDA wants this line, this is how it's been working. I think the class refractoriness is very important to making the decision. For example, somebody is on RVD, there are patients, all of us have that, transplant, R maintenance, couple of years, slow biochemical relapse. Good patient for the clinical trial. Excellent patient. This is how we do. But in the real world practices, okay, when it comes to you for the CAR T, now you have a debate. This guy is 5 years out of Revlimid, did great. Why I'm going to push him for the CAR T now? I'm just going to put it something, increase the dose. What we do, increase the dose, change the therapy, add CD38, buy a couple of more years, then do the CAR T. I think it's a valid argument that when you introduce these agents. So that's what the scenario for that. So I think my only point is we have to take into the consideration of class refractoriness rather than lines of therapy as our decision making, who is right fit for the CAR T.
Patients that have 10 lines of prior therapy as of trials there, they're usually very good patients. If progressive, they will do great whatever you do for them. Really, the main concern is the patient that relapsed very early, very aggressively. And those are the group of patients that we struggle with.
Yeah, so the redirect, I mean, I participated in that trial, so I can tell you that we patients who have pretty aggressive disease, EMDs in livers, stomach, lungs, we did notice the great responses using the 2 bispecific earlier, and even the CAR T data was not even as impressive as the redirect data was there. So there is a value of T-cell engineering therapies, giving it early in high-risk patients.
I have a comment. I'm trying to understand the point of focusing on this frail, functional high risk. We all carry some definition. We know they relapse early, whether that's FHR 24, FHR 36. I don't know how many extra number of patients you're going to capture with that. I think you can't have a conversation about early use of TCRT, because I know you said that we're going to keep it to the second half without the toxicity aspects of it, right? We believe in general, there's a subset of patients, like you said, they're going to do fine, whether you just give RVD 5 cycles, a little R for a couple of years, and they're off therapy and they're living their life. That may be 10-15% of patients. We don't know because we don't really understand their biology that well. There's going to be 15% of patients who are going to have TP53, 414 amplification. We know from the get-go, we got to give them a quad, we got to do transplant, we got to do tandems maybe, and then add a doublet maintenance or something of that nature, right? And then when they relapse, CAR T is going to come first to our mind. And then the rest of the patients are somewhere in between. I think TCRT is, we all do CAR T, we do clinical trials, we believe in that. But when you have unpredictability of your toxicity, and you're the one, and that risk is not modifiable, I think, how you said that earlier, and there's Parkinsonism and you can't reverse it, the patient's going to blame that. And that's the hard thing to let go of. So the toxicity that comes with doing early CAR T, the delayed toxicities, the second line conversation cannot happen without that, whether they're functional high risk or they're extra high risk or they're standard risk. But I bet you that the ultra high risk with triple hit or double hits, as well as the ones who relapse a couple of years after their initial therapy, will take that risk
because they know their biology, disease biology is behaving. The standard risk patients may not. And the same goes for your last question. Well, what about your bispecifics? Well, Majestic 3, I think infection risk is 50%, right? Like, it's very high risk. So we got to modify that. We improve upon that. And I think we have more basis to doing this early on. When it comes to, when I counsel patients on CRS and icons, I think usually patients are scared of that initially. Like, oh my God, I'm going to be in the hospital for 2 weeks. What do you mean my low blood pressure? I'm like, don't worry. We know how to pick it up. We watch your inflammatory markers. We know when you're going to have a fever. This is how this CAR T behaves. And we have antidotes that, and, we know how to counsel them on mitigation factors for CRS and icons. Yeah, on HLH. Yeah, and then throw the kitchen sink at them. We do know them, but it's the real hesitation of the use of CAR T in second line is toxicity, 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 and toxicity.
I cannot agree with you more. Yesterday in my clinic, I have 2 hours discussing about this issue with one of my colleagues who is a radiation oncologist, smart. Where I practice, people are well educated. They read everything. When they come to see you, particularly the kind of practice I do everything. I better know what I'm talking about when I go into the room. This issue come out all the time. What happened 5 years down the road?
Yeah.
What happened down there 10 years down the road? As Dr. Sigus, I've been practicing for a few years now. Most of these people will not die from myeloma. I have 18 years myeloma patient that's still with me now. And those are the things that now start coming to my mind. I say, wait a minute, what am I doing? I saw this data. The higher infection with CAR T, the better outcome. But now when I look back about some of the toxicity I'm seeing, I can take care of CRS on my sleep now, and I can. That's not a problem at all. My problem, what happened down the road? This doctor yesterday for 2 hours asked me all these questions. Ishmael, why do you want me to do this now? What happened when I have this, when I have that? They read everything. I think that's one of the challenges in the community practice that we face all the time. And these need to be addressed.
And so I think that's where all this risk stratification comes into play. I mean, what's been striking to me in the T cell redirecting era is that we come up with the same risk factors for poor outcomes. Like it's not as though we identify risk factors for poor outcomes for T cell therapy that are different from the risk factors for poor outcome with quad, conventional PI IMiD therapy. It's actually all the same. So we're not able to use this risk stratification to help select which therapy is right for the patient. Really what it's doing is informing, I think, the discussion about risk. Right. Who are the patients? And I'm starting to think of them along the lines of what you were saying earlier, David. Who are the patients for whom myeloma is likely to be a life-limiting illness? Yes. And those are the patients in whom I can justify these risks. Yes. And then the patients for whom myeloma is unlikely to be a life-limiting illness, I can pick and choose which therapies. I don't have to use all therapies for that patient. I can pick and choose the ones with the best risk benefit profile and maybe set aside things like auto transplant or more toxic CAR T cell therapies. But I despite my kind of rant before, I think second line CAR T does make sense for some patients who have these risk factors that they're gonna have poor outcomes. And you can take some risk with them, and that's justified. But in the patients who don't have high risk factors, I think you can be more selective about risk of serious toxicity. And I think that's what this paradigm allows us to do, where myeloma is not automatically going to be a life-limiting illness for every patient.
But the hazard ratio is so high in CARTITUDE 4, Dr. Garfall.
Sorry?
The hazard ratio in CARTITUDE 4 is so high, CAR T cell versus, let's say, DPD, that it's hard to ignore that you say, okay, CAR T cell has toxicity, we are not giving.
This FHR, the functional high risk 36 is important because these patients were all quad exposed. So the CARTITUDE 4, your standard of care was DPD, right?
So before you brought up an important point. If you look at a CARTITUDE 4 patient eligibility criteria, everybody has to relapse within 3 years of line maintenance. So by the definition, they were functional high risk even before. Now they you can argue that in general they were high risk patients. So I agree. I think that the benefit of the CAR T is so profound in that CARTITUDE 4 is difficult to ignore, in all comers. I totally agree. I think in the standard risk patients, the discussion between, like risk versus benefits, we have to discuss. But in high risk patients, which by CAR-T4 is all high risk because they relapse within 3 years of line maintenance, which, after transplant, we used to call this high risk before in triplet era. That really is the data stand out. Now, the question going back to is, now we have Majestic 3, where 5% of the patients were dead exposed. Majority of them probably disabling patient population second line. How comfortable you are offering bispecific combination versus CAR-T in the second line if they're already dead exposed? I'm not that comfortable because we really don't know. We have to wait for Majestic 9 data to see how the independent effect of. Then you are comparing the monotherapy of tech versus CAR-T, which we know that in late line CAR-T was superior. So I think this is a really complex where we cannot make one single decision based on one aspect because these things are moving so fast. And the patient population is disappearing as you go forward, right?
Yeah, we could do something crazy like do a clinical trial actually comparing these different approaches.
Yes,
I think that's 6
I think like a 10-year readout though.
maybe.
That's 6 data.
Actually, I mean, all these trials are reading out PFS and overall survival.
MRD or.
Since these trials do take longer, how comfortable are you guys making choices on an MRD negativity outcome? Because if we did do, like, say, CAR-T versus Daratech, and the outcome that we're looking at 5 years from now is just minimal residual disease.
I think
is that sufficient to make choices?
I think it has to be MRD with imaging because a lot of these patients are relapsing MRD negative with systemic disease. Yeah.
But also, I think you need to pick the population because I think we'll have this exact same conversation several years from now, all because really we're talking about mixed group of people and you hear this over and over again where we're struggling with how to define hazard ratio for the one person in front of us. As a whole group, the data stands, right? Hazard ratio is beautiful. You cannot argue against the 0.17, but it's 0.17 for whom? And I really like the idea of functional high risk because I think all of our so-called cytogenetic high risk were actually looking backward, right? So you have these people who've already been on therapy and you retrospectively analyze, could we have grouped them in some ways at the start? But now we've changed therapy. So the so-called high risk features, some of them will stand and some will not. I mean, we see the hazard ratio landing right across of each other for certain cytogenetic high risk that's probably irrelevant anymore. But I really think that it's probably going to require not large studies, but actually more targeted for the niche population that everyone's probably a whole lot more comfortable enrolling them because we need the answer for them. And then everyone else who's sort of like, relatively slow progressing, second, even third line, they do have other options. I think what patients ask me today, and I struggle a lot with, is, well, now you're having the data that has matured after some time. And patients ask, but if I don't do the CAR-T, what do you think will happen in the next 3 years, 4 years? The choices would be very different. Like really.
So I'll tell you a question that I struggle in my clinic is if you have a patient second line who has a slowly progressing disease and how comfortable you are not offering the CAR-T for that patient?
It's not whether we offer, right? I mean, you discuss it, but at the same time, I think there's sort of like a leaning. Maybe it's sort of like as you're weighing all of these available choices because they're all approved. I mean, you look at the NCCN guideline and we're also really at fault in that it looks like a shopping list. Of all of those things, though, as people are starting to weigh toxicity, they start to say, well, is it a high risk, high risk?
My question different. What is your choice of regimen in that setting, in the second line?
I think I would agree that, the people who are behaving poorly, people who are double hit and all of that, we will feel a whole lot more comfortable leaning into a technology that certainly has helped the most necessary population. But I think as a whole group, it becomes harder to say that second line is really the right place for everybody. I mean, really, you look at Pomdex Dara data, if you get 4 or 5 years out of it, or even a few years out of it, when they relapse, their choices will look very different comparing to what we are looking at right now on trials, right? Because trials require people to do one thing or another. There's also another group in that we assume that if they don't actually do CAR-T in second line, they will go into the third line with active disease. But also in real life, if you don't actually get what you want, if you don't get deep response, you don't wait for people to relapse, you just move on. So I think there's more granularity there.
You brought a very important point. I fear that on third line, if I wait for them the third line, they may not be able to get to the CAR-T because the disease tempo takes off and we may not be able to. That's my concern when somebody.
I will say that, I mean, I agree with both of these, but we can't predict for everybody, but we try and make the best guess that we can. So if someone presents to me with, so I don't, let's say I haven't been 36 months out. I don't know if it's functional high risk by FHR 36, but they had a huge disease burden. They clinically went south very quickly in the preceding illness prior to diagnosis. We do a transplant. Let's say they get 4 or 5 years of mileage out of it, and they're like, now I'm relapsing. I'm still not high risk. What should I do? So I'll have a context dependent discussion with them. I will, just like I try and offer everyone the benefit of a transplant, I offer everyone the benefit of a CAR T cell in the first line setting. And then when they ask me, look, what do you really think might happen to me if I don't do this now? Well, there's somebody that I think, if I really think, look, you could go a few years, I'll say we can have that discussion. And if I think, look, I think you're going to have a bad relapse in the next few years, then I'll say I think I prefer to go with the CAR T cell. But I have to do this individually, like you're saying, because that has to be based on the person's individual course. I can't take the one size fits all here.
36 months, if you show 18 months, there is a 12 months post-transplant, lack of response. Each scenario is very different. I think it's also important that patient factors needs to be into the consideration. Second line versus third line, one of the key factor is patient needs to make the decision. I mean, you give them an information that he may have a preference to go for therapy for the time. He doesn't want to come to the clinic other than IVIG. So sometimes the things change based on the perspective of the patients. Now, this TEC3 data, the data on you've been showing that, I think it's not applicable to the US population in majority of the places because they are exposed to the quads and there's very small number of patients. Now you're going to DVRD patient relapse or refractory, you're going to put them on this one. I do see you will ended up in some challenges with an insurance and other things even if it's been approved. So there will be a challenge to you using the data in a relapse refractory patients, using it with the bispecifics, the US population.
But sorry, go ahead.
No, I mean, first of all, there's a lot of patients who out there who got frontline therapy without daratumumab and have been hanging out for a while in first line therapy. And so those patients progress. I think Majestic 3 applies very, very well to them. Majestic 9 is coming soon, right? It's already out in press release format, big PFS and overall survival benefit in a DARA refractory population, I think, with overall survival benefit at the first interim analysis. So I think that question of applicability of second line bispecifics is going to be a very short-lived question because I think we're going to have an answer to that question very soon as those data come out. I think it's really compelling, I think, to choose bispecifics over CARs in that second line population, either DARA exposed or DARA naive.
So I think Al brings a great point. So when you give a specific treatment for any patient, whether it's a 3-drug regimen or a 4-drug regimen, my question would be, did the patient exceed my expectations or did the patient not meet my expectations? Because if I'm giving a 3-drug regimen and a transplant, my expectation is this patient will be progressing in 6 years. So you bring a great point. So this patient is 10 years beyond. So why am I taking a risk in this specific patient? Contrary to that, this patient is progressing, forget about FHR 36 or anything. If the patient is progressing at the 4-year mark. So my discussion with the patient is very, very different.
Yeah.
The way that I look at this is this patient did not meet the expectation of what my expectation for that specific induction regimen or transplant is. The same thing goes with every line of therapy. So that's where I offer either a CAR T or a T cell redirecting therapy based on what my expectation for that specific patient is.
But you're choosing the CAR T for the patient who has sort of suboptimal response or suboptimal, earlier progression than you would expect. So what I would want to challenge the group, though, is that I think the presumption was when you look at the phase 1 trials of CAR T cells and bispecifics, the presumption was based on those data that the CAR T cells are more effective because you have 97% response rate versus 65% response rate. There were always reasons to doubt that the difference was that large, right? Because the CAR T cell population of those trials was selected for patients who could wait for manufacturing, who successfully manufactured a product. We all know that if you participated in the early line bispecific trials, how many patients did you enroll on a phase 1 bispecific trial who could never have been enrolled on a CAR T cell trial? I think what you're seeing now in the early line readouts of the bispecific trials is that there is very little difference in efficacy and in potency between the bispecifics and CAR T cells. You can't honestly look at, the Majestic 3 and Majestic 9 data and say that those data look worse than the CARTITUDE-4 data. You could maybe slice and dice the population, but there's not a significant difference in efficacy between those modalities in the early line of therapy.
But right now, there's not a good predictive tool of who is going to be that population that's getting that 3+ years out of the bispecific. And
But it's 85+% of the population.
My concern and my worry is my patients that are higher risk. And if I'm going to fire off BCMA, we have plenty of data telling us about the order of operations. If you're going to do a CAR first, you're going to buy more time doing CAR than a bispecific versus bispecific into a CAR.
So I would challenge you about how much we actually know about that sequence.
We have a ton of data when we're doing this at first relapse. There's no data yet.
Yeah.
So this data needs to mature so that we have some sort of kind of subgroups. Like we keep talking about 3 different subgroups of patients. And in this middle group, I think we're actually pretty much all aligned. It's the very, very, very slow progressing, great responders to frontline and these functional high-risk people that we're debating on our definition of functional high risk.
So I agree with Al that bispecific are behaving differently in the early line than the late line. I mean, the Majestic 5 data is also proof that, this is so powerful, and Majestic 3 and I think Majestic 9, you saw the PFS of the hazard ratio 0.29, almost similar to CARTITUDE-4.
Yeah.
I agree. I think we have to wait what the real magnitude of PFS benefit in that with that individual. The one thing that I think I also struggle in the clinic is the quality treatment-free interval. That I discuss, especially when you have a patient, you have really equally effective treatment.
Yeah.
Toxicity is one thing. The also thing is treatment-free interval and the patient, how they feel, the quality of life. I mean, that's unfortunately we cannot predict in terms of toxicity for the CAR-T, but I feel like patients who have been on CAR-T and have really enjoyed this treatment for interval for a long time, they want another CAR-T when they relapse. So that part,
But you see, we're taking away that we're giving lymphoma little mind, we're giving them additional treatment that took away
post-CAR-T.
Post-CAR-T.
Yeah.
And I think it's going to take us a while to get the data for this, but I really do think the future is going to be that we treat that patient with the 6 to 9 month course of bispecific and second line, and they get the same treatment-free interval that they do after a CAR with the bispecific.
It's quite compelling even to look at the PFS curve. You could stop the treatment at certain time and they still will.
And then BCMA is preserved when they progress down the road. Their T cells are healthy.
First, not A or B. It's like what first anymore. So I mean, to be truthful, then we'll have to actually look at the chance of getting to CAR-T in the Majestic 3, which, gosh, I will retire and we won't have the data. I will retire. But I mean, vice versa for the CARTITUDE-4, then you'd have to look at the bispecific in the space where those patients relapse, which of course, because we liked the data we saw, we didn't really offer that as an automatic control, right? Because then you'd have the 2 trials that are really occurring in the same timeline, also capturing reasonably similar study arms on both sides. But it wasn't the intent and we won't know it. So at the end of the day, we are left with the real world and we're all criticizing the real world data to say that, well, there was a lot of selection bias because there were people like us actually carrying out conversation. But I think I wanted to go back to the high risk in that I think you're onto something though in the so-called functional high risk, because I think that functional high risk isn't just a factor that's on the tumor cell side. We're still stuck with the fact that we're looking at genetic makeup of the tumor cells. And that's only half of the story when we move into the T cell engagers. I mean, then we may actually need to keep changing the functional, the high risk definition, because it needs to actually take into consideration of the immune phenotype as well.
I think it's functional high risk. I think defining the prognostic factors, I think will change as time goes by. We don't know what are the prognostic markers for T cell engagers or CAR-T. We know that you have, 414, Velcade is great. You have 1114, venetoclax is good, but we don't have a characteristic definition of who responds and who doesn't respond to those treatments. We're just treating everybody and then we try to figure out what it is.
Here is going to be who's treating the patient at the relapse. And I think the premise of the conversation, the premise of this conversation is the patients don't make it early enough. And as bispecifics are going to get engaged earlier, especially if they're high risk, because I'm seeing these referrals, docs don't want to give up their patients. And if tech is available at second line, I'm going to give it. And then we are going to see, I'm of the belief C before B. But we're going to have to deal with the situation where patients, the high-risk patients would have already gotten teclistamab from the community, and we would then have to contend with what type of CAR T we're going to go with. So
the community, we are giving teclistamab maintenance in a clinical trial. We are giving upfront now teclistamab for induction. So I think the landscape is going to be changing. And in 5 years, I don't think we will be discussing is CAR T the best option. We'll try to figure out what happened to those patients, and we really don't know how they relapse and what kind of markers you'll be dealing with.
there's going to be another surrogate marker too, and that's going to be clinician stress-free time as well. That's going to be added on to clinical trials, because if I have to give my phone number to my patients and say, hey, call me if you have lower back pain and lower extremity weakness, that's going to be a factor. So that should go into clinical trials as well.
So clinical trial, my stress is high.
Clinician reported out. CRA is query physician stress.
The blood pressure readings and heart rate readings of clinicians when they do CAR T.
I have a question for all of you, and this is relevant to what Gurprakash just brought up, and then we're going to go to break because we need to take a break. This is all engaging. We're planning programs and all of this for the community doctors here at DAVA. What do you want us to tell them? Should the story be you need to be sending your patients for evaluation after first progression?
Yeah.
This is part of kind of our plan. Like we've been talking about quads for a couple of years now, but I think the plan is
that kind of concept is Janssen, for example, decided to open a community clinical trial for teclistamab as an outpatient with TUSI, which means that every community physician have access to a clinical trial that sounds good, effective. So you see them when they progress on teclistamab in your clinic. So I mean, we are saying something, but then we're doing completely the opposite. Oh, you don't need to send them to a tertiary center. Here is your teclistamab with TUSI as an outpatient.
So I think we need to tell our referring practices that what they're sending them here to see us for is our expertise.
Right.
It's not a particular therapy. It's because we are swimming in this stuff in a way that they could never be as general oncologists. Yeah.
This conversation, and none of us can agree on what to do, and you guys are all the experts. So just imagine the conversation we have with the community doctors that are also treating breast and lung and everything else.
When you do these things, it shouldn't be, when the patient goes through CAR T and X, Y, and Z, it should be like, hey, what do you guys actually do at this discussion? What are you focused on? And then you bring the 2 or 3 experts that you bring in from academic centers, and you have them and then many of the things that are pointed out should be pointed out in that conversation, so they'll know that it's just more discussion and conversation and educating them on what their options are. And then the patient is at the center of that discussion who makes a decision.
So, I mean, I think this is a larger question around partnerships and education.
Yes. Yeah.
We encourage, all the people that I work with in the community that, hey, whenever you have a new myeloma patient, please send them to us for a transplant evaluation. And so we can sort of plan what the long-term course is. I stay in touch with those patients. I see them every 6 months or annually or thereabouts, depending on the patient. And I think then we develop a partnership, we develop a mechanism of doing this, and they understand. Up until not too long ago, I would still get a young patient sent to me after a triplet for a transplant. No quad. It would drive me nuts. But,
So what's the definition of community? I'm just struggling with that. What's the definition of community center? When you mentioned that, is it somebody who doesn't do the transplant?
And we have a wide variety of different programs we do.
I think that interpretation needs to be, clear, because I can tell you a lot of institutions, they don't have transplant, but they feel they are in academic centers. I mean,
No, but they have to be, you need to see, there are published data on outcomes in seeing a myeloma specialist versus not. And so that's, if you are a myeloma specialist, whether you're in a place that does transplant, doesn't do transplant, but if somebody, your colleagues or someone else can say this person does myeloma all day long, then that's a person.
Who defines the myeloma specialist? What is myeloma specialist?
This is a beyond ethical discussion.
That's Twitter.
So it's important that we
actually go back.
I think I have an answer for your question. So there was a trial that was recently done, a collaboration between an NCI designated, not necessarily a comprehensive cancer center, an NCI designated center collaboration with the community. The myeloma patients live longer when the community collaborates with a specialist. So the definition is that specialist is under the umbrella of an NCI designated cancer center.
Okay.
So that data clearly needs to be shown so that it is almost like paving a path for a collaboration to happen.
Right.
Yeah, respectfully.
I think we don't realize is
Come off bad.
how the community is changing. Like in
Yeah.
our area, for example, there is large groups. So you have ES oncology with 10 people in the practice. And actually, you'd be surprised that
They're
one or two of them are
specialized too.
focused on heme malignancy,
Right.
Yeah.
common breast cancer. So you are seeing some specialization
that's
in
true.
the community.
It's changing very fast.
And it's changed. This one guy who sees everything is really falling out now. You're
Yeah.
dealing with large groups and with hospital-acquired groups
Yeah.
that have some form of specialization, and that changing things a little bit.
There's a problem you get to the East Coast, when you go to the boonies of Texas, 8 hours away, someone has to take a plane to see you. That's not true. This kind of specialization is not available in very much Alabama, Mississippi, Texas, all these other states where they're vast, and you know yourself, like, Amarillo, and I had a patient come in weekly flight from there to get, I think back then I was giving blood rep. But, so that specialization doesn't exist there. But I think it's a problem we have on the East Coast.
Yeah, at least I see it a lot. 30 years ago, everybody used to go to Arkansas, and that doesn't happen anymore.
No, I want to go back though, and when you were actually, because of course, in a way, I feel very privileged to be sitting at my little ivory tower, and I get to offer all of these fantastic things to people. I never know who I don't see, right? And I think it's relationship is one thing, but I'm not sitting in the patient's room. I feel that patients who actually say no to CAR T or even bispecifics, who are already, for the most part, coming in with the idea that they don't want to do it. And this is actually not something that their doctor is familiar with. It's not something that their doctors are supportive of. I mean, sometimes it's how things are presenting that's already sort of going to influence that first conversation. But also, I think we don't have a great way, at least my center don't have a great way to help patients coming into me. Now, once they are actually slotted in to get CAR T, resources are available. But I think that if you don't have people coming through the door and they literally have already gone through the burden of figure out, their resources, their caregiver coming in to park, to wait and all that. I mean, if we're really going to say, well, in the meantime, you want to be able to be sure that people at least have access to something. We don't want people to die and not having access to CAR or bispecific.
Yeah.
Sure, putting resources that are actually letting communities being able to give these agents, great. But I think it also has to be that it needs to not be so hard to actually also get patients into us, so that this relationship isn't dependent on the local doctor figuring it out or us figuring it out, because none of us actually have capacity to dance in that interface. But actually your ground troops know these offices really well. And I think resources that put in to sort of say, if you have myeloma patients, rather than calling Dr. Ali's cell phone directly, please actually give resources to actually assist patients to be referred to myeloma specialized center for a conversation, not for a CAR T, not for bispecific, just to know best about your disease so that you're well supported. And I think it'll go along with what AJ was saying, that collaboration has already been shown, but it's only shown because people have already been talking. We don't really know who we don't capture.
Tara, I think you bring up one last point. I think you bring up a really good point. I think there is a scare with CAR T that the community does not understand, right? And the patient is only going to walk through the door because they have so much faith in the community doctor who they have been with for so long. So we have to work on the community doctor, only then will the patient come, right? And that work with the community doctor obviously is our own personal relationship, but I think what Dava is going to be able to do, or other, troops on the ground are going to be able to do, is share the data and say how effective treatment is the earlier you refer, right? I think convincing the community doctor with the data is very important. And knowing that they will get their patient back is another aspect to it. So I think the transition aspect from the academic to the community, and the community doc knowing that they will get their patient back, I think is very important. And the second point is also educating something that everyone has alluded to in the room as well, is that the sequencing of CAR T and bispecific, because bispecific is coming in the communities earlier than CAR T is. And that's not because of myeloma and lymphoma, it's because of solid cancers, right? So their ease of using it is going to be so much more than doing CAR T. They get to keep their patient. So we need to work on it now.
Yeah.
Right? We need to work on it now. So I think starting early is going to be better.
Yeah, that's my apprehension actually, as I'm thinking through designing this program, is if we're sharing Majestic 3 is going to be approved or bringing it in, I don't want it to become well, I can give Majestic 3, I don't need to refer my patient yet. I think it's so much more nuanced than that. I'm going to Dr. Malik the last one. And so politely, and then we need to go to a break.
Yeah, I was very good kid when I was in the school. Yeah, lots of compliments. I'm using that the same skill. Catherine, I just want to add another things. I mean, very good points, but I think patients' education, like a grassroots movement, that's extremely important. We at Roswell, we send a letter to patient address. Patients that they had 7 years were basically during past 7 years transplant. We thought that they already had relapse or whatnot. So we send letter to patient address, and our clinic was shut down for all patients that were calling us. It's totally different than convincing community oncology. I think that's a very good effort and it has to be done. But to add to patients' infrastructure like Health3 and all of those, I think is very important and is investment for future of myeloma therapies. That if we convince, and coming back to Dr. Ali's point, that the definition of the high volume myeloma centers, there are 10 patients newly diagnosed myeloma per year. So if you convince patients that they have to see one person in those area, I think that's an investment for future.
Great idea. I think patients, getting them comfortable with these therapies. I can't remember if it was Dr. Gupta or Dr. Carr that said patients think of this as like a voodoo medicine. I think we need to work with Pixar to design a movie to really make this a very approachable understanding of how, your little soldier cells are going in and they're going to attack the cancer. And it would make a cute movie. Anyways,
Osmosis Jones. That's what you're thinking. Osmosis Jones is what you.
Super well ad. Super well ad here.
Make sure everyone understands that myeloma therapy accessible.
No problem.
Please take a 10-minute break. Have some coffee and pastries. We'll see you in a few minutes. Everyone, we still have to have the promised toxicity conversation, which is such a huge piece of the puzzle. So I'm going to have everyone please return to their seats. Grab one more cup of coffee so you can keep up with the conversation. Thank you, everyone. All right. I do it. Well, I need the little dung, 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 dung. Yeah, I need the dinner bell. Maybe I should get one on my phone and have it be ringing. That would be nice. Bring what up again? Yeah. Can we get my mic turned up a little bit? Can we get the mic turned up a little bit? Hello? Testing, testing, 1, 2, 3. We're gonna come sit back down. Please grab your coffee. Please grab a soda. Because as we all discussed, the toxicity piece of the puzzle is such an important part of this conversation. So we really want to make sure we have time to give it its just dessert. Thank you, everyone. All right, so everyone's going to come sit back down. Dr. Mazzoni is going to kick off our second half of the program for toxicity with some abstracts on predicting and then mitigating the risk of delayed neurotoxicities after CAR T therapy. So how do we predict who is going to get these toxicities, and what are some strategies we can to potentially modify them? And everyone's been saying these are not modifiable. Let's talk about that. Dr. Mazzoni.
Thank you. I am going to keep it brief because I'm not presenting anything that's going to be new to us, so that we can dive into some debate about this topic. Okay, so here is the data that we know from the real world and the 2 CARTITUDE studies that have long-term follow-up reported about any delayed neurotoxicity events, cranial nerve palsies, and then Parkinsonianism. There's a lot of ongoing studies that are focused now on trying to figure out modifiable risk factors so that we can have a more predictive tool, and then develop, the last section of this, we'll talk about treatment of these delayed neurotoxicities. So one of the things that we're all very aware of is this idea about what happens with the risk factor going into these delayed neurotoxicity events around the ALC, so that peak absolute lymphocyte count. There's a lot of debate that we'll go over here about kind of where that cutoff value is. First, the study here is looking at that cutoff of 3,000, and then also looking at response to bridging. So these are the 2 things that really panned out to try to have more of a risk factor that existed that is modifiable to reduce possibly the outcomes or target those patients as the ones at higher risk for those delayed neurotox events. So the progression of or stable disease versus a partial response or better. So partial response or better with the bridging therapy is one of the things that we're going to talk about along with that peak ALC. So delayed neurotoxicity related to that peak ALC, and how did it affect both the response? So it didn't affect the response to the CAR T product at all, but you do see that there's an increase or a peak in that risk of delayed neurotox when you have a higher peak ALC. So on here, they don't discretely tell you the exact level. On the next several slides, we'll go over this debate between a cutoff level of 3,000 to 5,000. So here, they're looking at both all delayed neurotoxicity events and then just Parkinsonianism. And there's more of a kind of a predictive tool about that level of around 3,000. So you can see there around all patients were 2,400. Parkinsonian cutoff was just shy of 4,000. Now looking at, well, no delayed neurotoxicity versus any delayed neurotoxicity versus Parkinsonianism, and trying to look at the sensitivity of these different levels. So if you use a level of an ALC of 3,000, or looking at a couple other factors in there plus an ALC of 2,500. Now, what are we all doing about this? So in the real world, we all have discovered that you can intervene prematurely in these patients to try to prevent a delayed neurotox event. And we've all landed on using different doses of dexamethasone or other steroid. So in here, this is an analysis of 39 patients refractory relapsed myeloma at Colorado Blood Cancer. And you can see that ALC cutoff is far higher. So they were looking at 7,000. And they then took a cohort of these patients, so 8 of them, and they gave intervention with prophylactic dexamethasone when the ALC reached over 5. When you look at these patients, so down here, do we have a, there we go. So this right here, these are the patients who did not have a high peak in their ALC. These are people who had a large expansion. And these are this little green here are those that had the large expansion but had intervention. So of the patients who got Parkinsonianism, looking at standard of care cilta-cel patients, so 22 out of 761 in this study, the risk of patients who did not get a good response, partial response or better to bridging, this is the patient population that had a much higher risk. So you see that p-value of less than 0.5. So that's the other thing we're going to talk about now is what about bridging therapy? What's a good strategy for bridging? And we're going to dive into this gentleman's study on TAL bridging. So one of the things that you can do, sorry, I'm one slide ahead here. So with the TAL bridging, we'll get to in 2 slides, actually. What they're looking at here is looking at the rates of all of these adverse events that are of special interest around all these delayed neurotox. So we talked a lot about both the Parkinsonianism, but also looking at the non-relapse mortality and the infection rates here. So you see that these infections here for non-relapse mortality are all based on responses here. So you'll see it going up. So the patients who have progression of disease, patients who have minimal residual, and this just makes sense. So this is going to be our patients who have more disease, more comorbidities, higher rates of disease probably going into the CAR T. Looking at the patients who had better responses, they have better survival. Also makes a lot of sense. But here we actually can see it in our real database. So patients who had a partial response or better have better both PFS and OS. Now getting to this gentleman's study here. So looking at the patients that got talquetamab bridging, how many people in the room are using talquetamab bridging in the real world? Probably all of us, right? Now I think there's going to be a little debate around how to do the bridging. And then more importantly here, you'll note with the NODE study, there was 19 patients who got some talquetamab prior to collection. So I think that's something that we will need to talk a little bit more about, and I'm going to rely on our expert here in the room on more, how did those patients do? What kind of responses did they get? And for me personally, I really would like to understand, did it have an effect on the quality of the CAR product? Okay. So looking here, focus on the green here. So these are the patients and where they're at going before CAR and then coming in after. So you are expanding with the TAL bridging the number of patients who have an excellent disease control. This is where we're at for progression-free with the TAL and the overall survival with the TAL. So these patients, they do have really good responses. And most importantly, look at what we're all agreeing upon is a very high-risk patient population. So these extramedullary disease patients really benefited from talquetamab bridging. Now the safety and efficacy. So there's always some concern when we're starting to do something new and we're starting to play around with T cells and using a T cell engager in the midst of a CAR. But it didn't seem to really affect the expansion of the CAR product. You do note here that of course, we all know this about talquetamab, and we all know that we're seeing it even with just using very small period of exposure to talquetamab. So in summary, the high peak absolute lymphocyte count here and a robust CAR T expansion seem to be consistently associated with a higher risk of developing these delayed neurotoxicity events. What we don't touch on very much here is the kinetics of the ALC. So there does seem to be a role to looking at the kinetics or the rate of the CAR expansion as probably a predictive tool as well. The other thing here is about the depth of response going into CAR. So the better you bridge and the better you reduce that CAR T burden of disease that the CAR T is going to have to go up against. So that brings into this idea of more of a debulking strategy for all of these really high risk patients. So that's my question to Binod, is those patients who did get some tau exposure before collection, were those the ones you're kind of trying to debulk, and how did they do? What was
There's no choice but to use
Yeah.
something.
correct?
And that's what they, I mean, this is a retrospective study
Yeah.
with the 19 patients, and majority got CAR T. Almost 19 out of 19 and 16 patients got CAR T. There were only 2 manufacturing failure, 1 had an out of spec product. So
Yeah.
I mean, it's again, it's an evolving question. We really don't know what is the optimal washout, right? And I think majority did have washout for 1 month. And I had success in 3 out of 3 patients for 1 month washout, but 4th patient had no success. So I think it's really kind of we have to probably individualize which patient and what is the optimal washout before we collect the T cells. But on average, I think at least 1 month washout in that study.
Yeah, I mean, we're gonna have the option to use off-the-shelf CAR T cell products in those kind of
Correct,
patients.
those
So
kind of patients,
It's a
yeah.
question that's gonna be a relatively short-lived question.
Yeah.
That you end up actually as a bridge, not as a pre-leukapheresis, but as a bridge, you actually end up with a dual targeting approach, being that the half-life of tau is actually quite long. And when you're coming in with a BCMA bispecific, sort of like no surprise that there's potential added anti-cancer effect, right? Because I mean, we see in the redirect that combination of bispecific actually.
So we
gives you
have
more
right now a
benefit, but-
clinical trial with this same concept. We enroll a first, second patient now, and where we're looking at the antigen status at baseline and at multiple time points, and looking at the how it impacts the GPRC5D as we go forward. So these antigen will be checked on these patients at periodic intervals to see if that has the exposure by itself with the talc would have any impact on the GPRC5D.
With IHC or with genetics?
We're doing with genetics.
Genetics.
Uh-huh.
How you can say, because
so you
it's
can
not
do
on the surface though.
No, you can do the gene acid.
It's not telling the surface occupancy.
No, I think that part we cannot figure out. I think if you look at the GPRC5, it's a little bit different than BCMA. Most of them are monoallelic loss happens in 15%. And complete loss after tau, if they're progressing, happens in almost all patients. But there is a kind of a concern that even the brief exposure could impact the GPRC5D, that people would lose it. So the idea is that if that happens really in these patients, we don't know. I mean, the idea is that, you could potentially kind of re-challenge this. So again, I mean, there is no complete picture we can find out, but we'll look into that study, and hopefully that will help us.
I think that the talc bridging is an effective tool, so which I do agree with that when published. But in the real world setting, what I'm struggling with, if somebody gets the toxicity of the talc, we are delaying the CAR Ts, and this is getting a longer and longer period of time. I mean, no, I understand the disease going to a little bit suppress, but that's a challenging part because of its toxicity, and it can be negative for the patients too. This has been seen after the publications, 6, 7 patients that I did. 2 or 3 patients ended up with this type of delay because of the side effects can be challenging. And
Talc side effects.
Yeah, because of the bulky disease, and this is where you make the decision to give them this type of bridging. So that's a challenge that I've been struggling with, the bridging. Now back to Dr. Mazzoni, your question about ALC part. I think this is the problem with this, again, the real world data. They collected day 7, day 14, 21, 28 with the absolute lymphocyte counts. How many patients have ALC of more than 3,000 and they do not develop any problem? And I think this is the issue of using the prophylactic dexamethasone. It is the right approach or not. So if you can have some idea on that, that would be great.
There's a couple things. One, I think that there needs to be more about the kinetics, not necessarily the absolute level. And 2, we are actively proposing to the consortium to look at the outcomes of these patients where we did intervene in order to do some sort of preventative strategy around what we felt were higher risk patients for delayed neurotox. Like, did it affect the quality of their CAR, the length of their response? We don't know. And so I think when we're talking about this, I don't think it's a matter of, is it okay to intervene to delay this? I think it's how much is too much dex. Like, there's so much debate within our own group about, oh, we should use 10 Q6. I don't give that much. I'm at the total opposite
So
end.
it's clinically
How many days do you guys give them on
So
that?
before, may I answer your question? And
Yeah.
the first one, what is the risk of delayed toxicities in patients with ALC more than 3? So there is a combined studies from all CAR-T programs. We had EHA poster last year, and it looked at the risk is, so if you look at the delayed toxicity, the risk is about, especially Parkinsonism is 3% in the real world, right? In those patients who are more than 3,000, the risk is about 8 to 10%. So the risk almost doubles.
Yeah,
So it's interesting because I think Mayo Clinic just published like a TCT where they said they did an internal comparison. They did 120 patients. So they had 230 patients. They looked at their database and then they did 120 patients prospectively, ALC greater than 3,000. And then they gave them Dex 10 milligrams, I think, twice a day for 3 days when they hit that. And they saw that there was no difference in delayed neurotoxicity.
That
And
is the thing we don't know, right? That's so is the kinetics, is the Dex, I think Al can probably explain the mechanistic. You guys did some cool mechanistic study recently, looking at CD4 independent expansion. So I don't know, this is, again, it's not like, clear.
So agreed. Like, I think for me, this is the meat of the meeting today because, we all agree CAR T is good, right? Whether we do it first line, second line, third line, that can all be questioned, right? But like, I think what I was mentioning early on is that to have a risk versus benefit discussion with the patient, we need to evaluate risk and we need a good way to determine what is risk. And the biggest things that we talk about are IEC, colitis, delayed neurotoxicity, Parkinsonism. We need to have a good way to determine that. And I think clinically, I mean, Dr. Nuka showed really nicely, like, the kinetics and the CD4 expansion and the Tregs go up and like, that's great, but I think clinically for us as clinicians, what do we do? So I think ALC is the one thing that's come up, right? Burden of disease is another thing that's come up. So by a show of hands, I want to know, like, how many of us in the room use prophylactic dexamethasone right now with our patients?
Everybody uses.
We're using it now, but there is a problem with this data. Like, this 3,000 comes into the picture, and what about if you have a 3,000 and nothing happened? There are many patients who have.
Clearly, right? I mean,
So you're just doing it like a post-transplant high. This is what it is. So trying to.
So first, I think it probably doesn't work. And so we'll get there eventually, and we'll run it too, but I think it probably doesn't work. A couple things. First, we did just publish this study that Binod mentioned, and I think one contribution of our study is that we didn't just look at neurotoxicity, we looked at this whole list of immune-related AEs, the enterocolitis, the rheumatic syndromes that emerge in some patients, we had some pneumonitis. And actually, it's the same predictors for all of them. So even though they're clinically heterogeneous, the ALC predicts that just the same. And also, so they all have the same underlying immunologic features. It's just for some patients, it manifests as the Parkinsonism, others, the enterocolitis. What was interesting we saw in our cohort was that if you look at the CD4 to CD8 ratio at the time of apheresis, you could actually come up with a two-factor model. So if your CD4 to CD8 ratio at apheresis was greater than 1, your ALC cutoff should be lower in terms of predicting risk, ALC of around 1.3. Whereas if your CD4 to CD8 ratio is less than 1 at apheresis, it's the ALC cutoff of 3.3. And if you put those two factors together, you come up with a 75% risk or so of developing one of these immune-related AEs. So not just the neurotoxicity, but any of these AEs. The other thing that we saw just looking at our patients was the mortality if you got one of these, if you put them all together, was about 20%. Mainly from infections because the patients were getting so much dexamethasone after the fact. And so I think if we could identify an early intervention that could prevent exposing patients to a lot of immunosuppression down the road, that would be, even if we were over treating a few patients, that would be very worthwhile. Unfortunately, we're doing the same thing with Dex, but I found the Mayo study kind of compelling. And the CBCI study, I admire what they did at that very earlier time point, but it was like a tiny number of patients. And so I think, unfortunately, it doesn't work. And it could be that by the time we're seeing that ALC go up, the cat's out of the bag.
That's the
and I think that what would be really cool is to look at the company that makes this product has all the manufacturing data, right, on these products. And now that we know who these patients are, can we go back and identify factors that happen in the manufacturing of the product or the apheresis that we send to them that can predict this before it happens? Because probably by the time the CAR T cells are expanding rapidly, there may not be much you can do.
And may I ask you a question? How ALC rise in first week can cause late neurology 3 months later?
Well, so there's a couple. So one, I think one question is whether the ALC rise is the cause or a manifestation of an
the T cell expansion.
Right? Yeah. So that's that these cells have a biology that predisposes them.
That's a surrogate of CAR.
Surrogate of massive
If you
expansion.
look at the data, not in this study, but the one that I mentioned, the CAR T study, were directly proportional. The ALC rise and CD4 expansion, the CAR T CD4 expansion is directly proportional. So each time, but I mean, ALC is a surrogate for the CAR T expansion in this case.
The point is, everybody, I think, respond to DEX in terms of ALC drops. In our experience, like anybody goes to 3,000 and you give BID, DEX 10 or whatnot, everybody goes down, but some of them still they have late neurology symptoms and some of them they don't.
Yeah, in our experience, the ALC does not always go down.
Yeah, some rebound too, like you stop it for 3 days and it just like shot right back up. But I mean, I find your comment interesting in that, I mean, of course, we are even at the point of care able to do T cell profile at baseline before collection. But I'm not sure, even if that was the data, it seemed to be the ratio is a cut and dry kind of number. You're either below or under, but how would that actually correlate to the profile of the expansion in the in vitro and also the product that we infuse? Because all of this ALC doesn't come with the T cell profile, because in truth, you don't want to reduce everything, right? You just only want to reduce a subpopulation. And I think you're right that dexamethasone is really, I mean, it's just poison to the lymphocytes, but you're hitting them all, not one population versus another.
But we're using the TOSI prophylaxis on day +5 and using DEX still among patients who go to ALC of greater than 3,000.
Gets TOSI.
TOSI at day 5.
Because
If somebody has CRS and day 3, they get it, so they don't get the prophylactic TOSI, but everybody else gets on day 5. And
regardless of ALC? Okay.
So you're just ICANS, AJ?
ALC happens after. So what we're saying is, so we'll have the abstract in IMS, but the ALC expansion, as we saw in the past, has not been as much in this cohort. And when whoever that's happening, we're using DEX.
And what is your experience? How many patients you have done so far?
So we have done close to 45 patients or so far. And we continue to, so we don't have, we'll be putting an abstract for IMS.
I think they're onto something. So I personally check this big panel of patients. It's not standardized at all. Like we just check CRP, ferritin, and ALCs, and then kind of sort of an immunodeficiency panel, but it's not perfect. I also throw in a cytokine panel that we have in-house that's actually fairly inexpensive, shockingly. And I track all of these things. And then in my own head, if I have a cytokine.
This is inflammatory cytokine.
Yeah. Which it would.
Which ones are those measured? Which cytokines?
It measures 5 different cytokines. So it's something that I'm playing around with, but I would love to be able to do something like what you're doing, where I just stop this inflammatory mess that's probably driving all of this in the first place.
Yeah, it's
the IL-10, IL-6, IL-12.
But the one concern I think your paper raised is there any antigen-independent expansion of the product that is just expanding? So that is something that of course you didn't test that clinically because you don't have expansion of those patients, right? In your study.
So what we did was compare not from the patient samples, but ide-cel versus cilta-cel for different signaling, trying to understand why the difference between the two, right? Because I think the hypothesis was that, cilta-cel has double binding, so it's more avid. Actually, there's no difference in avidity for BCMA between cilta-cel and ide-cel. There is a significant difference between CD4 CARs and CD8 CARs, though. So CD4 CARs have a higher avidity for target, and they're more responsive to CSF cytokines. So cytokines, you can take CSF from patients who get neurotoxicity, and they recruit CD4 cells across a transwell more effectively than patients without neurotoxicity. And there's a significant difference in antigen-independent signaling between ida-cel and cilta-cel. So ida-cel actually, when it binds, has a little bit more rapid activation, but the antigen-independent activation state of cilta-cel is more, and then sort of tonic signaling is more than with ida-cel.
So you're assuming that the relevant expansion is driven by target, our target, rather than the T cell's original target. So, is there any thought that there's a tropism that is driven by the native TCR in those populations? So I've been trying to get our guys to look at T cell repertoire in those patients. Is it compressed versus broad? So those T cells have their own inherent tropism, and if we're seeing sort of an oligoclonal expansion of a subset of those T cells, that may be the driver of these kinds of toxicities rather than via the TCR.
So our group looked at this patient who had this massive expansion of under a white count of 150 and had 3 different immune-related AEs afterwards. It's extremely polyclonal. There's almost no clonality in terms of integration site or TCR clonotype. It's extremely polyclonal. It doesn't seem like there's a clonal selection for specific clones.
I'm talking about selection through the native TCR, not based on the CAR construct.
No, but if there were something going on with native TCR, you would expect certain TCR clones to be enriched in the expansion, and that's not what we see.
And not at all.
It's interesting though that because the whole sell for ida-cel was that there was lower tonic signaling in the first place, right? As compared to because the single chain variable fragment is identical to the NCI product, and so the whole fact that it had lower tonic signaling was supposed to make it more efficacious while less toxic. But then with Carvykti, being so much more active,
it also lasts longer in the blood. That is very surprising. If you look at the persistence for the ida-cel, it's much longer than Carvykti.
Yeah, and so ida-cel does seem to have less tonic signaling, but it's possible that the tonic signaling maybe helps at some level with the efficacy by promoting the expansion, perhaps. So I don't know. I'm not a T cell biologist, and so these studies weren't done by me, and there's bigger questions there. But yeah, there are some differences between
the tonic signaling means antigen independent.
Correct.
Yeah. So, but it's not clear that the persistence and the expansion is the relevant phenomenon. It may be just an epiphenomenon that just characterizes that product as a more effective, more viable product, rather than that it's the expansion itself that is the driver of efficacy.
So whatever gets inflammatory cascade going, just
Yeah. So
everything.
yeah. So there's all these questions that still need to be answered. The reality of it is a lot of these questions are going to go away because we have a whole line of new products coming along that don't have those kinds of toxicities to the degree that Carvykti has. So what's the difference between the look of the patients with abecma that aren't getting this number of these kinds of toxicities, and we should be able to answer them. The problem is that the companies haven't given us all the tools to answer those questions.
If the cellular engineering changes, right? You went from CD28 and gamma retrovirus, and then took the same single chain variable fragment, put it in 41BB with lentivirus, and you get abecma, and it's a whole different efficacy and toxicity profile.
Yeah, and anito-cel is not based on an antibody at all.
So can I ask a quick question? So coming back to the TOSI prophylaxis. So is your abstract going to say that TOSI at 5 days plus DEX when you need it after that, if there's still expansion, produces a lot less delayed toxicity, especially neurotoxicity?
There are a few endpoints that we're looking at. So there is one of our basic scientists. So priming them with IL-6 he believes that there's an efficacy aspect as well. So that is one reason. So number 2 is stopping off what are the inflammatory milieu that's just being triggered very earlier on is the second endpoint. And the clinical endpoints are absolutely the response rate and the toxicities. We're doing a sequential cohorts. So we know exactly when we started. So we take the same number backwards.
So I ask because with prophylactic TOSI, we don't use prophylactic TOSI. But with prophylactic toci, you know what to expect for the immediate CRS and so on. I guess the question is, what can you expect 3 months later, the median day 43 that you get with Parkinsonism and so on? Does that change things?
We're eagerly looking for a formal analysis.
About ICANS, Ajay, those in lymphoma that prophylactic toci because expose more interleukin 6 and ICANS increase.
We have not seen that as a
You have
signal
not
at
seen
all.
that. Yeah.
So
And I think that was mostly with Axicell.
Yeah.
It's a product with intrinsically, I think, higher risk of ICANS.
I see.
our data from the bispecifics where we use this as prophylaxis for a while, we have not seen any zero. So that's what we'll see.
Like in the bispecific, it's always in the setting of CRS, but the ICANS with the PAR is a bit more delayed, so the kinetic alone may be different between the two groups of drugs.
No, I hear you. It's a long half-life, right? So Tosi has probably 15 days half-life.
So then,
Yeah.
I mean, this may be a challenge. So in your patients with bispecifics that were getting, so they're getting Profitosi, no Dex, right? So then it's always, no, that's good.
But probably Dex with the doses, right?
Pre-med though. There's
Yeah,
not
if there's 4 milligram pre-med for everybody.
No, but then that's if there's, because we always worry, right? I mean, I personally don't like using Tosi because I don't have solid data to back this up, but now and then I feel in the older, frail patient who may easily, get upset with this apple card up here, Tosi drives a little bit of the I can. So I try not to
For
use
bispecific or CAR-T?
CAR-T for sure.
CAR-T.
Now, because when you put an 89-year-old patient on a bispecific,
For a
a lot of 89-year-olds are.
I would make more of a case for a bispecific because there was the Polish group has published recent at EHA with telcatamab with giving Dex plus Tosi for telcatamab. Grade 2, grade 3 toxicity is 0 CRS. So if you want to do it as an outpatient, you do a combination, not one or the other. So that's what I'm preaching to the community.
I think they give Dex in addition to the pre-med.
In addition to pre-med. So they're getting on 3 days before.
Yeah.
And I think the concern about higher IL-6 levels after Tosi is a bigger concern if you're giving Tosi in the midst of CRS, in the midst of an IL-6 surge, because you're kind of getting rid of the sink. But if you're doing it in a preventative way, arguably you kind of turn off the feedback loop beforehand.
Alfred, in your study, did you look at the chip panels too?
So the team has looked a little bit at chip, and I think the story is not straightforward yet, but it's tough. But I've had some patients with bad.
I have that. So I have this TET2 mutations and things, and those are the ones that are developing Parkinson's, and TET2 is known to cause inflammation. So there's a lot of theory behind it. It's not only just immunogenic markers.
Yeah,
I think we're missing some
host factor, right? I mean, that is completely unknown, not understood, because clearly, like when the legend first did the CAR-T in China, I mean, none of these were reported, whether it is underreporting or it's not seen versus it's reported now. I mean, it's clearly there might be some factor, which is, host factor, that one of them could be that one.
Well, Cy/Flu makes a difference too, I think. I mean, it's very clear that the more intense lymphodepletion leads to higher levels of expansion, and the initial legend studies use just Cytoxan.
Cytoxan, yeah. But I think there is one cohort to the flu as well. I mean, there are 3 different cohorts, no? In the legend.
Was there? I thought it was also Cytoxan.
So, yeah.
I forget.
Yeah.
Long time ago.
Do any of you guys do any more exotic interventions, intrathecal interventions, and have any of them work?
Well, I think
And actually,
That's coming
next
next one.
be the next talk. So I think it's a perfect segue. Thank you, Dr. Siegel, to bring Dr. Zakal back up to the podium. Let's go through our last data set and continue our conversation.
All right, thank you so much. Now, in the last 10 minutes, I'm going to briefly review some of the management strategies that we do. I mean, no, there is no right or wrong answer. We have so much of variation or variability in the practices of what we do because we really don't know what caused this and how to fix it, right? So managing delayed toxicity, this is very kind of a simple outline that was recently published in Lancet of how to identify and manage the different toxicities, specific delayed toxicities. The CAR-T mainly pertains to cell-to-cell, but when you look at the MNTs, which is one of the kind of probably most dreadful toxicity for a patient, this is associated with the BCMA CAR-T and maybe more with the cell-to-cell, but has been observed with Abecma and perhaps some with the other BCMA CAR-T. So whether it's a class effect or something else, we still need to understand it. But this is mainly, associated with the presence of a lot of CAR T cells in the blood, and also in these patients when we do the lumbar puncture, most of them have high level of CAR T in the CSF as well, mainly manifested by the three main changes: personality change, then cognitive changes, and also movement disorder can have just flat effect. That could be the presenting symptom, whereas some patients have a full-blown Parkinsonism-like syndrome. The next one is cranial nerve palsy. I've only seen the cell to cell. The good thing is that most of them are reversible. I would say 99.9% of the patients in my practice had resolution of this cranial nerve palsy. I must say I had one patient who had still ongoing after 3 years, but he started grade 3 and now is grade 1, but it still has that. But almost everybody has resolution of these toxicities. Mainly affects the facial nerve and could be unilateral, could be bilateral, but facial nerve seems to be the most kind of common one. But we have seen in other cranial nerves as well, like oculomotor nerves and even trigeminal neuralgia can also be present. The lastly is the peripheral neuropathy with the GBS, very rare. It has been actually described in CD19 CAR. Even bispecific antibodies has been described, like alvanatamab. There was actually they put a thing on hold because of GBS case. There are some other CARs has been reported of GBS. I haven't had any patient with the BCMA CAR T getting this, but I had seen in one bispecific patient with GBS, again present with the ascending muscle weakness and motor symptoms. That is very, very clear, the rapid progression that you really have to intervene very fast, and the outcome is really bad in these patients. Now, how to manage this MNT? When you just look at the MNT, again, there is so much of a heterogeneity of what we do, and there is no right or wrong answer. In our practice, I will tell you what we do, but here this is some outlines. But probably in more or less, we do this for all the patients, like getting neurology consult, getting MRI, getting lumbar puncture, making sure you rule out other infections and potential other etiologies, and starting immunosuppression, starting anti-Parkinsonism medication, which usually doesn't work. Then if they improve, then just watch them closely, do this assessment of handwriting assessment and all those close monitoring of the symptoms. But if they don't respond or they progress, then it becomes a bigger problem. Then there is a second line treatment. There is none. The people use, there are a lot of cases have used even Jakafi, they have used cyclophosphamide, some have done IT chemo. At our center, we do IT chemo for essentially everybody with ICANS and any neurological toxicity, including the cranial nerve palsy. So, whether that really helps or no, we really don't know. But unfortunately, this is an area where you really need to understand the mechanism of who are the patients who are predisposing to that and what is the effective intervention strategies. So going to the IT chemo, this is a case series that was published in U Chicago group. As I said, we do that for all our patients with ICANS, and they did in 5 patients. They all had some form of MNT symptoms, and of all 5 patients, they started systemic corticosteroids, intrathecal chemo. You can see this cytarabine, methotrexate, and hydrocortisone, which is triple therapy that we use for all patients. And one patient, I think, if they didn't respond, they also started thiatipa at 10 milligram with hydrocortisone, who partially responded to the IT chemo. They had, out of 5 patients, 2 had complete resolution of those symptoms. And then one patient had IV Cytoxan intubated because that didn't respond to the IT intervention, and one of the patient had no response to any of the treatment. So clearly, small number of patients, there might be some suggestion that IT might help, but whether this IT really helped or because of steroid help or this is supposed to get better with time, we really don't know in these cases, right? Because small number of patients. The other one is Cytoxan. People have done Cytoxan. This is a case report, I think, from MGS group. They looked at 13 patients with a non-ICANS toxicity, including the cases with the Parkinsonism. Out of which 6 patients received high-dose Cytoxan. It's a 1 to 2 gram per square meter, pretty high dose. And some of the time, these patients will need to make sure they have some stem cell left because they might need to give the stem cell boost as well. Out of the 6 patients, 4 patients with neurological improvement, you can see the characteristics of these patients with the ALC count is clearly remarkable here in all these patients. They are very high, and they had improvement in 3 days. And 2 patients had complete resolution up to a period of about 3 months. Patient 2 required a second dose of cyclophosphamide 12 days after initial dose, and that improved. Patient 3, unfortunately, had a competing risk of death from COVID-19, partly contributed by the high-dose Cytoxan because of immunosuppression, and patient 5 and 6 continue to exhibit unresolved toxicity. So, again, this small number of cases suggests that there might be a role of this kind of intervention, mainly immunosuppressive intervention, but really there is no hardcore or large-scale data to kind of guide that. Now, going to IECHS, I think somebody mentioned this is one important risk that we have to take into account. Fortunately, I would say that recently we have very few number of patients having this partly because we're decreasing the disease burden quite well before they go into CAR-T, and perhaps we are intervening early than what we used to intervene, like early TOSI and even prophylactic TOSI or probably DEX early. That probably would help in this, happening this IECHS. And this could happen right after CRS, in association with the CRS. Sometimes they can happen delayed IECHS. And this is something that we really need to keep an eye, especially some patients who have already recovered their counts and come back after day 28 with the, dropping the counts, platelets coming down, and then fibrinogen coming down and ferritin going up. So this is the ASTCT monitoring guidelines and management strategies. Again, every center has the different approaches. I think one of the most reliable marker in my practice, in our opinion, is a ferritin. Ferritin is a very, very good marker to identify these patients a priori, especially the doubling time of ferritin. So at our institution, what we do is we look at the ferritin during the time of CRS twice a day, especially when there is doubling, and then we start, we have a very low threshold to kind of think of IECHS and also start intervention very early on. But at the same time, there are a lot of other features. I mean, we really do bone marrow biopsy to diagnose this, but we don't have to rely on the bone marrow biopsy to give a diagnosis. But in some centers, I think, do it to make sure that there is a hemophagocytosis happening, maybe in severe cases. But there are a lot of multiple other markers, clinical markers and lab-based markers that can tell you this patient is heading towards IECHS. And the key is to early intervention. So if you look at the management strategy, the first line is anakinra, and we all do that in our practice. Usually, the starting dose is 100 milligram 3 times a day sub-Q, but we usually start 200 milligrams sub-Q 3 times a day. Unless somebody is very big, then we start IV. IV is usually reserved for ICANS, but usually, that the dose is depending on the weight of the patient, and steroids is always given, and the goal is to kind of taper it very quickly if there is improvement. If not, then you add in some other agents. I have done Jakafi at the MOS. I have not used this ipilimumab. We tried for one patient, but the insurance didn't approve it because that is mainly approved for primary HLH. But in general, I have seen a lot of this done. But in general, steroids and anakinra seems to be the first line and seems to work very well. So what we do is we look at this ferritin doubling time, and if there is doubling time, we see the ferritin rising up very quickly, we start actually prophylactic anakinra if there is an indication of some other indication of the HLH happening, and we taper it very, very quickly, 200 milligram 3 times a day. In matter of next 3 days, we really taper it as long as the ferritin is coming down, and that has really help these patients. I would say that I have not seen any grade of high-grade IECHS in the last 2 to 3 years. I mean, that used to be the case when the CAR-T was first available in the early days. The other new entity now we're finding out is IEC colitis. And again, in the same with the MNTs, the exact pathophysiology of this is not really understood, whether it's a undiagnosed or kind of unmarked T-cell lymphoma. It's the infection that drives the CAR expansion in the GI tract. We really don't know. The putative pathophysiology, there is a polyclonal CAR-T expansion in GI tract, which is a immunologically rich environment, right? So it's prone to get subject to all these things and does the damage. And once it goes to the point of no return, whether it is driven by the infection or something else, then whatever you do, it probably doesn't help. And that's what has been the clinical observations. Now, this is again a case series that was just recently published from MGS group, where they looked at Jakafi as one of the tools to treat the IEC colitis, and that looked like pretty good resolution with improvement in 1 to 7 days. I have not used Jakafi. I had so far, very knock on wood, only one case of IEC colitis that was driven by this norovirus. And we did some of the immunosuppression. Unfortunately, the patient didn't get better. I have not used Jakafi yet, but would love to hear the group what they do in these cases. But this looks pretty encouraging, to see the response in all 3 patients. Second, primary malignancies after CAR-T. I think this is independent of the product. I think this is a risk that happens in most of the CAR-T product, and this is the data. You look at the id-cell and cilta-cell in CARMA and CARTITUDE-1. At the longer follow-up, you will see the SPMs rates higher. SPMs rates higher, 4 to 5%. The id-cell in CARMA and 8.5%. Especially when looking at the hematologic malignancies, that is about 2% in a range. I mean, the question is, who are those patients? What predisposes these patients? Are they living longer? That's why we're seeing this. I mean, myeloneoplasms is an inherent risk in most of the myeloma patients, whether it's a transplant or lenalidomide maintenance. we see these patients risk all the time, but what CAR T does and how it does kind of affect that and what is the mechanism behind that is still not clearly understood. The one thing we know for sure is that the latency period from the time to CAR T infusion to the development of this second malignancy, especially the hematologic malignancy, is very short compared to let's say transplant followed by lane maintenance, which is a little bit longer. So that tells you there must be some kind of expansion of the clones that is already there before the CAR T. This is one case of the CAR T cell lymphoma. This is another entity, and that potentially one of the risks is integration of the CAR vector into this, kind of a tumor suppressor gene or the clonal gene, and then that can expand the clone. And this is one case where the patient has a T cell lymphoma in the cutaneous T cell lymphoma, and that was confirmed that he had the CAR positive, and this patient also had the TET2 and EGS2 mutation at the time, but they didn't have in the pre-CAR samples, and the patient was treated with the mogamulizumab. I think this is CXCR4 antibody that is approved for these patients, and with the doxorubicin gemcitabine with complete resolution. But again, this T cell lymphoma, whether it's a cutaneous or systemic T cell lymphoma, has been observed, has been reported in CARTITUDE-4 study as well, in other studies where you are seeing the direct integration of the CAR T in that T cells. So this is a summary of the T cell malignancies, extremely rare events, but do happen, and this is definitely a point of discussion with the patient. Whether this happens differentially across the product, I'm not sure, because this is a random integration with the product, with the way the CAR T is manufactured, and whether identifying some of the risk factors, especially the chip mutation beforehand, really prevents this. We really don't know, because at this point of time we really don't have the data that you have this certain, because chip mutation is very common, and whether you can prevent getting the by kind of excluding those patients, we really don't know. Cutaneous T cell lymphoma can happen, and then lastly, if we have a method to kind of identify what are the factors, both kind of clinically and also genomically, that this is the risk that puts the patient to develop this, that would be fantastic. But right now we don't have the tool. So in summary, for the late toxicities, which probably seems to be the holy grail, and for the offering CAR T versus not, or comparing CAR T versus the bispecific antibodies, is kind of evolving and recognizing new entity that is really kind of as you go forward, we'll understand this more and more, and probably there might be new toxicity that will come up with time, because this is definitely a new therapy where we are learning more every time. MNTs, in my opinion, is probably the most dreadful one. That is something that is more or less not reversible in most of the cases, unlike the cranial nerve palsy. IEC-HS and early CAR T toxicities with ICANS and CRS, it's probably we are more or less better at managing that right now. With this earlier intervention, we don't see grade 3 CRS in our practice, and most of us, we do even outpatient CAR T. I must say that our center, we do almost all of the commercial CAR T outpatient. I have yet to admit a patient with the grade 3 CRS now or grade 3 ICANS now. So that tells you how much we are learning, and hopefully we know the way that we are learning and manage early toxicities. We also know how to manage the delayed toxicities with time. There are a lot of immunosuppressive medications that have been implicated, that have been shown benefit, but there is no one uniform or one single agent that has been shown to benefit. And that tells you how we need to understand these patients, both at the clinical level and the genomic and the microenvironment level, to understand the risk and the management strategies. So with that.
Thank you so much, Dr. Dekal.
Can I ask one question about the enterocolitis? So why does it happen that the timing is typically beyond that 100-day to 120-day mark? So by the time the CAR T cell persistence is gone, so what could be the potential pathophysiology for that and the timing?
Yeah, I mean, that's
the colitis happen?
Yeah, it's the same thing probably with MNT, right? If you look at the MNT that happens, usually average time is about 40 some plus days, right? The median time to onset is 40 days. Cranial nerve palsy happens around 20 days, that is median time, and this IC colitis usually about 3 months. So that is much later one is the IC colitis. I really don't know. I mean, that's something, whether the damage happens and that is triggered because there is something happens around that time, like infection. And I must say that, one case, the patient had a very bad norovirus and initially improved and then got worse. So I think whether that kind of expanded the initial damage, what has happened during the CAR T expansion. I don't know if any of you have other ideas beyond that, but I think it is the damage initially insult is done by the CAR T, And then on top of that, other factors play into role as the patient go forward.
So I wouldn't disagree with that. So we've had 3 patients now with IUC, and maybe a fourth that I'm going to see on Monday. So the first patient who had an IUC was deceased. We treated him with just straight steroid, came under control quickly, was discharged from the hospital, was somewhat non-compliant, didn't call in when he had a fever and sinusitis, and that's what killed him. All right, so these next 2 patients, I think both are Carol Ann's patients. One had IUC, received everything from steroids to Jakafi and vedolizumab, but still continues to have diarrhea many months out. A current patient who's in the hospital developed IUC at 7 months and is on Jakafi right now, has received vedolizumab ×1, maybe 2. I'll find out when I start in service in a week if she's received her second dose. But I think to some extent, all of these patients probably had some degree of insult somewhere during the CAR T cell process. All right, so this fourth patient is my patient who I'm going to see again in follow-up on Monday. He's had plasma cell leukemia since 2014, right? He had an allo transplant. And over the last 2 or 3 years on salvage therapies, he's had significant issues with diarrhea. He actually got his CAR T cells October of 2024. But he's had massive diarrhea now going on the last 2 or 3 months. And this extensive workup has shown so far lately that there's findings of some salmonella DNA. So salmonella. Right, so he's just started antibiotics for that this week, right? So like 3 days ago. So I'm going to see him Monday because he's followed by one of my colleagues in the community, and we'll see where he is. And I suspect he probably does have IEC because when you look at all the images and all the reports from the GI guys who were in the community, none of it mentions IEC because it wasn't on their radar. And once we get the path slides and have them reviewed here, what I expect the guys here will say at Hopkins will say is that we think this is consistent with IEC and maybe the infection is the driver or contributes to that. But I would agree. I think he had some. I mean, it's not a very sick. So that's a good point, right? He has never had any degree of GVH, right? So ever. So
I mean, you get sunburn.
The patient had allo
but none of that. His allo transplant was in 2014. So could he have GVH now? I mean, he has no other findings whatsoever of GVH. Also, what was on the radar for the GI guys that looked and the pathologists that looked with his recent colonoscopy was GVH. They didn't see anything that they thought.
I mean, he got salmonella precipitation.
So I mean, so where the GVH starts, one starts and the other begins is a bit difficult to say, but that remains to be seen. So does Jakafi help? We think it does, but I don't know if that's the only answer. There's enough inflammation in some of these people that it's ongoing for an extended period of time.
Have you ever used topical corticosteroids to treat the colitis?
Budesonide? Yes, it doesn't work. It doesn't work. It doesn't work.
But
No.
No,
it doesn't help. To treat GVH, I mean, as part of GVH therapy, sure.
Even as this, it doesn't help the IUC.
Yeah,
All of these guys have had it.
So I think so I think like last year at IMS at the IEC meeting that happens in March, from Yale, they presented a group of, I think it was 9 or 12 patients, and they looked at like these patients who developed IEC, like what were their characteristics? And majority of them had nerve palsy, right? And then they are the ones who went ahead and developed. And at that time, as Dr. Thakur was saying, that we don't know what actually helps these patients, right? So steroids mostly don't help these patients, whether topical, I mean like budesonide or systemic. Jakafi has been tried. This data from MGH is actually pretty compelling and it's helpful. Vedolizumab was tried, not helped. I had a patient with IEC, developed within 4 months. She had she had created nerve palsy. Nothing worked. Unfortunately, we tried infliximab as well. She died of fungal pneumonia because of
they all die from infection.
Yeah, they don't die. They all die from infection.
I mean, on TPN for weeks.
Exactly.
Not eating a thing, and I mean, it just looks like profile wise, they look like they've been just like in starvation camp, and then with little bits of pneumonia, then we lose them. And it happens also in people who come in with low tumor burden. We had one clinical trial for newly diagnosed patients who actually die from IEC.
And what we saw was that the risk factors for the colitis were the same as the risk factors for the neurotoxicity, and they often co-occurred. And what's interesting too is as we think about earlier lines of therapy, I mentioned that CD4 to CD8 ratio at apheresis is predictive of risk, but if you look at CD4 to CD8 ratio in early lines of myeloma therapy, it tends to be higher. And so I think we on one hand, okay, more disease control, et cetera, should protect against this as we move to earlier lines, but it also could increase the risk of these toxicities because the product is going to be more potent because you're starting with healthier T cells.
Yeah. I think looked at other biologics other than TNF alphas.
The vendolizumab is the one that I think folks have used, but
The thing is, we have hard time even.
it's like some kind of chemokine receptor. I don't know what it targets.
Yeah, it's one of the newer ones.
It's an integrin or something,
Our
right?
folks sitting in back, they have a huge rheumatologic component to their
Yeah.
company as well.
We have like CTLA4 that probably plays some role, and probably, I mean, it goes back to the uncontrolled expansion of the unnecessary subset, I think, of cells. But then also with the localized stimulation that end up, like how do you explain why someone actually will have a GI issue down the road while they might have already had some neurotoxicity early on that's actually resolved? So they're marking for the group of people who are sort of having unsettled issue. But also I feel that the extent of the enterocolitis is a problem, right? Because in some it's diffuse, it's everywhere. And in some, it's actually kind of like localized. It's harder for our GI guys to actually get to the diagnosis. Sometimes it even required repeated biopsy, particularly in the case of the viral infection, or for us, it was actually an E. coli. So you can blame it on the infection, but then, repeated biopsy. But the upper gut is involved too, which I think is interesting, because I would think that if it's really just like antigen exposure, that you'd be thinking more of the lower gut.
What's interesting too about, I mean, correct me if I'm wrong, Vinod, but I think this toxicity really was not reported in the clinical trial,
none of
right?
it. Yeah.
So this is something that became a black box warning based entirely on things that happened later, right, in the real world. And so
Reported as like a diarrhea grade 4 or something really that we didn't know, or infection, because it's actually repeated GI pathogens being identified.
Yeah,
A lot of the community docs don't know about it. Everyone knows
Yeah.
CRS, ICANS. I've had a handful just coming back routinely at CAR like 2 years ago, and the patient mentions, "Oh yeah, I'm having this diarrhea going." Like it's very delayed, and even some of the neurotox. There's the Parkinson's we see earlier, but there's a lot of patients that just have this ongoing neuro symptoms. They're not totally normal, and the family's like, "What is going on?"
Yeah.
Like they're a little more flat. They maybe have a little tremor, but it's not like full blown.
Yeah.
So I'll say
Those are very challenging, but the community needs to be educated, because I don't think they connect.
Is the data that was presented said like a 10% incidence of this colitis? I mean, is that consistent what you guys are seeing? Because I mean, you're describing like TPN requiring antibody.
I mean, not that
like
high.
I've not seen any patients
I would say less than
with that severity of.
I think 10% all.
Altogether,
Delayed toxicity is 10%. So including MNT, granulopathy, and that's the problem. Also is that they're all grouped into one big basket category, but each of them is different in terms of the outcome, in terms of management. So that is a problem, right? So we're learning this is a new entity and keeps on adding up. So, but we don't even MNT, right? So that is now being described like IEC Parkinsonism, but we really don't know what is
the comment I was going to make too about, you'd asked about AJ's study. You've got like 45 patients that you're going to report on. The data that was presented from Colorado had 40 patients. Like what's your expected? Like in 40 patients, like your single digit percentages, you're talking about a couple patients either way, like the random chance of one patient making a difference in a study being positive or negative. That's why we're debating like prophylactic Tosi or Dex, and Dex at what level, or Dex when, how much Dex. You can't tell from a study of 40 patients or 60 patients in things that have an incidence of single digit percentages.
Yeah, I hear you. So the big thing that was the driver, the first 40 patients that we treated, we never had anything. When people were talking about neurotoxicity, so like, what the heck people are talking about? 41, 42, when we had that, we know what the reality is. So we need to do something. So this is an intervention that we made, and we would see what happens with us. We didn't treat any differently. The same supportive care is what we provided, except we made an intervention. This will give us a hypothesis what could happen. Are we decreasing the CRS? I was in the inpatient service for the last 2 weeks. Nobody had CRS. I was discharging everybody on day 10. But again, this is anecdotal in the 6 or 7 patients that I had seen.
Yeah, but that's CRS.
Yeah.
Right, and we're talking about long-term delayed onset toxicities. You can't even.
All I'm saying is this is too early. They made an
Exactly.
advertisement, they'll wait for.
So Andrew, I will tell you my experience. What we do we had one case of Parkinsonism, and after that, I changed my practice to do DEX, not with the absolute number, but with the rate of expansion. So if somebody has a DEX of ALC of 0.4 the day, and next day it goes to 0.8 or 0.9 or 1, then I start DEX and try to slow it down. So I have done that intervention. And again, it's a single center study. We might have treated 40 plus patients with that approach, even more. I have not had any case of, we have one case of one or two cases of cranial palsy, but beyond that, no Parkinsonism, no IC colitis, nothing. So I think there might be something that we are doing, but the question is, when is the right time to intervene, and what is the better surrogate marker that we need to choose? That is probably, maybe perhaps your data will show the same thing, that is probably you don't see it. Similar to the talc bridging, at least the last follow-up, we didn't see any case of Parkinsonism in those patients. We had 2 cases of cranial palsy, and unless somebody tells me that, oh, we have seen now, but I have not seen any case of Parkinsonism.
So I think it's also geographical. I mean, we don't see much what you have mentioned it here, especially the colitis one. So I'm just trying to question it. Is it more like do you use the LEN before or the palm before getting into the the CAR-T? What is the impact of that? But the same questions come up about ratio of CD4 to CD8. So there is also the unknown infection factor that has been triggering it. I have patients even with bispecific horrible diarrhea for even stopping the drug, norovirus, same story. So I think there is a lot of unknown here, like how to characterize these patients, what screening workup needs to be done before they go to the CAR-T. We're still doing the same screening what we're doing for the stem cell transplant. So I think it has to be more patient focused. And I think there is a geographical risk, different area, different locations, out of spec versus the spec product, and what was the bridging therapy before was given. I think those factors needs to be into consideration when these ISCs are happening in the later period of time.
So one question for everyone in the room is, what is your strategy for infection prophylaxis after CAR?
IVIG. That's pretty much it.
What about Bactrim?
Bactrim 6 months, right? 6 months.
Do you follow a CD4 count?
Yes.
I leave them because they're returning back to sender. And I would rather they stay on Bactrim and stay on IVIG until their disease starts to percolate back than somebody drop the ball and then they die from infection.
But there's 2 caveats to that with the Bactrim and the bone marrow suppression, and many of our patients beyond. I mean, I've had patients who've had 6 months, they recover their counts after the first month and a half, and then have normal counts and then start to have drop in their counts. And then I'm dealing with neutropenia, thrombocytopenia. So I hate Bactrim for that reason. I do a Tovacone, but those things are expensive and there's high
and they're not effective, right?
So
yeah, I mean, that's ideal, but like not everybody, the game plan is return to sender, but come back to me every 6 months to do this correctly. How many of these people, we're dealing with real world issues. They relocate, they move, they lose their insurance. I mean, all kinds of things happen.
CD4 is dynamic. I mean, we stop it at 6 months, and then after a year came up, CD4 count is 100 now, back again. So I think that's the whole reason we change our protocol to change it to either Tovacone or Bactrim.
So you give indefinitely?
We give it indefinitely.
Now we change it.
Do you guys have any issue with insurance coverage for IVIG if the IgG is?
We will never have that issue again because we're really pushing for everyone who's on NCCN to put that in there this year.
Regardless of IgG levels.
I've been doing
irrespective.
Sometimes I get a talk with the insurance, they said, well, we can't do it. I've been fighting it because of that retrospective data.
We need it.
IgG subclass and convince them.
It is true that you still do get a pushback, but I think that once it gets to the to the peer-to-peer, that's usually when it goes through, because I think the first line denial is really not done by the people who know what they're doing.
That's what I'm doing.
And is your IVIG also endless, or do you wait for like immune reconstitution?
Yeah, that's the point. You gotta slow down and stop. Once the immune reconstitution happen, we don't need.
Exactly. Like once they're greater than 400 persistently, I usually stop.
Nobody's in IVIG after 15 months.
Yeah, exactly.
12 to 15 months, they completely recover.
Like past a year,
Yeah.
dosed it.
But first year is critical. So going back to Sandy's question, if you look at the number of death, non-relapse mortality, it happens most in the first year in the real world and the trial. And most of them are gram-negative infection deaths.
Right.
It's not even they have good neutrophil count, they're still dying because of the, I mean,
it's interesting with CARTITUDE-4 when you think about infections, the total infection risk in CARTITUDE-4 CAR versus standard of care is no different, but the timing differs. And so there's an earlier risk with the CARs, but a later risk with continuous standard of care therapy.
There are 8 deaths from COVID-19 in that study.
I still feel that the IVIG isn't necessarily, I mean, it reduced the risk for sure, but I think the location of the infection is typically where there's high antigen exposure. I mean, your GI tract, I mean, your pulmonary respiratory, I mean, you cannot seal the antigen from that area. So, and we cannot direct the IG to where we need it to be. We never fix the IgA, for example. So, but I support the idea of using it just, consistently, at least for the first year.
So what if something really stupid, like putting them on pre and probiotics and trying to keep their gut health? I mean, all of our solid tumor folks, they're all about this, like tumor or gut microenvironment.
Well,
And even adult folks.
Everything is about your gut microbiome.
Yeah.
And one of the things that we haven't studied in the myeloma world.
David has that running in the family, so.
We collect them, but we find that.
I mean, that would be way cheaper. Eat a yogurt. Bring in Jamie Lee Curtis and let's do it.
Actually, the lactobacilli in the aftermath of the stem cell transplant, the lactobacilli species, not necessarily the one that's in yogurt exclusively, actually have a negative correlation with inflammatory complications post transplant.
So we'd have to be smarter.
So it's the butyrate producing bacteria.
That's the thing.
It's one of the ones that you need.
It's probably more manipulated by the food you eat than probiotics.
Thing that we do, right?
Yeah.
Exactly.
And location of the place you live is very different. Texas versus New York is totally different.
Risk factors. But like modifiable risk factors, like we can't really overhaul everyone's diet. That's tough. But
This is work that we should, as a group, be insisting on that the impact of gut microbiome on everything. This is why our kids have allergies. This is why it's all about gut microbiome.
So microbiome plus clonal hematopoiesis explains like
Unknown, that's the explanation.
Well, look at your plasma cells in those patients who have CHIP mutations. You're going to find the same mutations in the plasma cells.
It is true.
So I mean, the reality of it is that myeloma is a stem cell disorder. It is, it isn't coexisting CHIP and myeloma. It is myeloma evolving out of the same cells that the CHIP is evolving in a subset of patients. This stuff is all crazy, and as we get to these massive, whole exome sequencing and RNA-seq databases, we're a lot of the questions that we have now are going to go away because we're going to sort of understand the environment and the disease so much better, and that's what machine learning is going to bring. Is the ability to analyze all these things that we can't analyze.
I like your optimism.
I think there's a trial going on at Sloan Kettering called the Nutrivention.
Yes.
Which is what
So
they're looking at, like giving them like this certain types of food and then seeing what happens.
There's turmeric.
That's about progression to symptomatic disease more than the impact on.
No, they're doing a study in newly diagnosed myeloma now too. As part of that, their new study is in newly diagnosed myeloma with the goal to look at survival outcomes in active myeloma.
Yeah, I mean we've been looking at these things for a while, but
it's interventional, which is nice. It's a controlled interventional trial, which is impressive.
I mean, it's a big one out of Sloan Kettering that's actually randomized to a certain extent. We have an interventional lifestyle management protocol, and it's all, like I said, it's all about the microbiome.
So I have a question about the chip. So since you're all talking about looking at chip, so if you find it at baseline, or say if you have the mutation even existing in your T cell, even though it's not done necessarily as a standard of care, do you take those patients to CAR? Or based on what it looks like, you're like, well, maybe we'll think twice. Or could we convince AJ to actually do the prophylactic approach for those folks who have biomarkers that may be more relevant?
Patients, they do worse no matter what, essentially. So,
But if you're going to take them anyway, I mean, you have choices then, right? Whether you are actually looking at this profile and you say, I'm chicken out. I'm going to pray that the next thing works, short of T-cell engagers, and I'm not doing it. Or I'm going to do it anyway, and I'm going to try my best at using all of these interventions that have maybe mitigate the inflammatory cytokines, but do them prophylactically rather than sort of like,
I
waiting
think
for
it depends on the
ALC.
type of mutation. Like, what you're seeing. If I'm seeing DNMT3A, TET2 mutations,
exactly.
I still proceed.
And those are the common ones.
Yes, I'll proceed with if I don't see any morphological evidence of the
I think morphological evidence is the key. I mean, chip by mutation, we don't have data.
No, we don't. But
I think it's an interesting
I-
question.
yeah.
It's such an interesting question to answer.
Yeah, but I'll give you one background. Parkinson case I had, I actually look at that patient's CSF for chip mutation because we don't have any answer. We tried everything, and I found chip mutations in the CSF. And I'm just telling that patient who has
This is expected, right?
TET2. So I'm just giving you TET2 is known for inflammation. Now we're theoretically thinking that this is all inflammatory process is still going on. So there's a lot of unknown. But it's difficult to decline somebody who has 20%, 25% TET2 or DNMT3, but no morphological evidence of, MDS or leukemia or things like that to decline the CAR-T at this time.
So I agree that we shouldn't decline it, but I do want to mention, I think at first we thought that the patients getting second neoplasms were just, okay, they're like late line patients with myeloma who are living longer. But I was surprised to see in CARTITUDE-4 that there is a difference emerging in the early line setting with not only the CAR T-cell lymphomas, which are a couple of them, but also MDS and acute leukemias. And so I think there is some selection going on in some way between the Cy/Flu or maybe the effects on the immune system that are leading to.
The idea is that the inflammation that happens around the CAR-T period, peri-CAR-T period, that expands the underlying clone.
Yep.
Yeah,
The
absolutely.
latency period is very short, exactly the point that you mentioned. Where you have transplant and then maintenance, it happens way down the road, right? But that is not the case with the CAR-T. It's like very quickly after the CAR-T.
Yes, the joke I've made sometimes is that all the things that people blame on transplant are actually more true of CAR T cells in terms of seconds waiting series and.
Rated occurrence.
So, but what happens with CAR T cells is number one, you're using a couple of drugs that you can point to that are pro-mutagenic, the fludarabine in particular. But then you're also profoundly immunosuppressing the patient for an extended period of time. Why do our kidney transplant patients explode with myeloma? Why do our kidney transplant patients develop all these horrible, cutaneous mutations, cutaneous malignancies, invasive squamous cells and things like that? The reason you have this accelerated thing that happens with CAR T cells is you're doing two things. You're damaging the patient's DNA and you're profoundly immunosuppressing them. So the ability of your immune system to interfere relatively early in the evolution of those kind of processes is all of a sudden gone. And by the time the immune system starts to recover, it's already part of the milieu, and the immune system doesn't give a shit.
And I would add the inflammatory.
So
that's one other thing you're doing there.
So just to point on that, even if a long-term survivor for the lymphoma CAR, you look at the reason for death is the second malignancies. Even the later, time, the risk is still there. So it's early risk is there, but at the same time, in addition to myeloma, we don't have that data.
Any of you seen the development of cutaneous T-cell lymphomas that then just resolve spontaneously?
No, I have.
We've had two patients who developed, cutaneous T-cell lymphomas. The pathologists say, yeah, this is the real deal. It's CAR positive. But then as the patient's immune system continues to recover, it just spontaneously disappears.
PTSD in a way.
So again,
It's almost like PTSD.
Yes.
Like, you take away the immune suppression and then the body just
There is a patient or two that has had some lymphadenopathy or something in the gut, and the biopsy says that there's a T-cell rich, possibly lymphoma thing.
So we looked at,
but not quite lymphoma. You wait a little bit, it goes away. I will say one thing. So the post-transplant kidney transplant patients who get the myeloma, their myeloma doesn't seem to be as horrible, any particularly different from anyone else's. The lymphoma, EBV-driven horrible lymphoma is very rare, right? So it is sort of interesting that there's more of a kick in one direction than there is in the other. I mean, for all my patients who've had myeloma post-kidney transplant, I managed to get them under control reasonably similar to other patients. This is the lymphoma that's very challenging, and some of the.
I think that people are aware that there's something goofy going on with the immune system immediately after, and that's leading to all of these toxicities. Because everyone's trying now. If you look at all the new CAR T studies, it's no longer CAR and then off drug. It's CAR and then partner with something that hopefully can try to get the immune system back a little faster without hurting the health of the CAR.
And you're saying that it's not, it's the chemo, it's the immunosuppression, and then it's all you give it all three, the big triad, and then you give the inflammatory kick and DNA damage, immunosuppression, inflammation. What else?
What if the old school double hit theory from like 1980 something?
Yeah, I mean, shows when you have that triad. Why is it shocking that you end up getting another malignancy?
I just think we need to be more careful though when we think about lymphoma versus myeloma, just because the average population is just older.
No, I don't disagree.
And they receive a lot of chemotherapy as well. They receive chemotherapy prior. None of the myeloma patients receive chemo. All the lymphoma people receive the first line R-CHOPs and so on, right?
So everyone, we are just going to give you the last word.
Okay, one comment. Truly, like, so, around the table, we all do DEX prophylactically, ALC greater than 3,000. Everybody, I'm sure every institution has something different that they do. Some may take 5,000, some may take 3,000. But like looking at we still see delayed neurotoxicities, right? Looking at the Mayo data, does that compel you to do it otherwise? Like, would you take it away?
Sorry,
something better.
No, do it. Does it? Should do it differently.
I'm asking a question it shows that we think that the ALC greater than 3,000 is a surrogate for delayed neurotoxicities. We think that we can give steroids and this will go away, but we don't see it. Now there's a prospective study that did that, and they said that it did not make a difference. So will that change anybody's practice?
In the absence of a better alternative, and also because DEX makes me feel better. I don't know.
So clinician comfort.
Well,
which is a very important thing. Which is a very
I think I'll go back.
Yeah.
So now we are doing a lot more of giving DEX when the ALC hits 3,000. But lately, for some of our patients, when I see the trajectory of the ALC going up, our NPs and we talk, and we're like, look, the ALC was super low the day before, and the next day it's 1,000. The writing's on the wall. It's just great to get in there. So almost done. I would like to see. I mean, we'll develop our data further and where those go, and if those tally with the Mayo data. But I don't have a better alternative right now.
I think it's going to have an effect on the physician quality of life.
100%.
So we can sleep on call. That's what that does.
Mental health.
Yeah.
Mental health.
Mental health and quality of life, which to Jansen added to your trials.
And with that, that's an excellent way. Guys, we could be talking about this for another hour, but I do recognize some of you have flights to catch. So thank you all so much for being here and contributing to the discussion. It was really interesting and I learned a lot. I hope you got a lot out of it as well. Thank you, of course, the industry partners that make it possible. And with that, I wish everyone a good afternoon. Have a great Valentine's Day and safe travel home. We'll see you at another Java program. It was lots of fun. Thank you guys.